Okay. So I think everybody saw the agenda. That we're asking up front for any declarations of conflicts of interest related to the topics on the agenda today. Sleep apnea. We have some public comments that are unrelated to the agenda today. Not hearing any. Okay. All right. And then
we'll do the orientation presentation and we'll do roll call. All right, so welcome everyone to the May 16th, 2023 meeting of the Health Evidence Review Commission. Is the recording started?
Mm-hmm. Oh, yes. Jessica, can you start the recording?
No, it is started.
Okay,
it's already in progress.
I see the red light. So glad to have everyone here today. Just as a reminder, Oregon Health Authority has set a goal to eliminate health inequities by 2030. Our purpose here today is to make coverage decisions. These decisions will affect over 1 million members of the Oregon Health Plan, as well as their families, caregivers, and providers. There won't be any decisions here about anyone's individual care. This is a policy body. Again, the decisions are about benefits and medical necessity for Oregon Health Plan members. We will be hearing public comment in just a few minutes. Decisions made here are not final until approved by this commission, and then they will be implemented at a later date. For most of the decisions made today, they will be implemented on October 1st. I think there may be a few that will be delayed until January. Our general considerations include the assessment of the balance of benefits and harms, as well as patient values and preferences, good stewardship of public resources, and just the nature of our healthcare delivery system. Sometimes we make decisions to accommodate for the nuances of how people get services in Oregon today. For those of you members who are online, we ask that you generally be on camera and attentive, although we understand you may have to step away. If you do, please direct message Daphne. And if you have any logistical issues, you can also message her. And when you're voting, if you're online, please vote in the chat. For those in the room, Liz will hear your verbal votes and put them in the chat so that we have a record. For those of you who are members of the public, you won't have access to the chat, but there is a Q&A button, and you can use that. If you're having trouble hearing or anything like that, you can message Daphne and she will do her best to accommodate you. As a reminder, chat and Q&A are part of the public record, and the meeting recording of this meeting will be posted online for posterity. All right, and as always, our email address, herc.info@oha.oregon.gov. We may or may not have time to respond to messages today, but we will get them as soon as we are able to. And with that, we can go on to roll call.
all right. Daphne, take it away.
You betcha. So we know Devin Consagra is here. Adrian Irwin.
Here.
Mark Buckholtz.
Here.
Thank you. Mike Collins. Stacy Geisler.
Here.
Max Kaiser.
Here.
Lisa Kouzes.
Here.
Linnea Lindsay.
On the phone.
Larry Lyon.
I am here.
Chris Pinzon.
Here.
Catherine Schabel.
Here.
And Leslie Sutton.
Here.
We are missing Ben Hoffman today, and it looks like my internet's not very stable, so I'm going off video.
All right.
We have a quorum.
Great.
And Mike Collins is absent.
Correct.
All right, thanks everybody for coming. The approval of minutes. So everybody's had a chance to look at the minutes from last meeting. Any questions or concerns? And if not, does anybody want to move to approve the minutes?
Motion to approve the minutes.
Second.
right. Anybody against approving the minutes? Not hearing any opposition. Approve them. Minutes or directors?
Yeah, I have quite a lengthy director's report. I'm wondering if we could just go to the public comment.
Sure,
So
yeah.
they don't have to.
Don't have
do
to
all
wait
that.
around, yeah.
Yeah.
Great. So I think we have 3 people signed up for public comment. This is not related to stuff that's on the agenda for today, but let's go ahead.
Great. Thank you very much, Devin. The first person we have signed up to give public testimony today is Adia Chirandolo. Her affiliations are Do No Harm and List No Conflicts. Our search showed nothing on the CMS Open Payments database. So Doctor Who's last name I didn't say correctly, I'm going to push a button to allow you to give your testimony. You have 3 minutes. Please begin by stating any other conflict of interest you may have and begin your testimony. Thank you.
Excellent. Can you hear me?
Yes, and would you please pronounce your name for us?
Absolutely. My name is Aida Chirandolo,
Thank you.
and I have no conflicts of interest to report. First of all, I just want to thank the Commission for the opportunity to testify today. I'm a board-certified emergency medicine physician with over 20 years of clinical experience. I practice in New Hampshire, and I am a volunteer for Do No Harm. Evidence-based medicine is the most compassionate care a clinician can provide. WPATH version 8 guidelines are not rooted in evidence and therefore cannot be considered standard of care. When children are distressed, it is natural to want to alleviate their suffering. Distress about gender is no different, but medical pathways of gender-affirming care treat one narrow presumed cause of distress. This approach appears compassionate, but it is not evidence-based, and as many other countries have concluded, the evidence for medicalization of children with gender distress is poor, and therefore this pathway does not represent best practices. Last month, British pediatrician Hilary Cass released the largest systematic review of gender-affirming care to date. Systematic reviews are the highest level of evidence analysis that guide best clinical practices. The Cass review found no way to predict which children will maintain a lasting transgender identity, no high-quality evidence for puberty blockers or cross-sex hormones, and no convincing evidence that hormones reduce the risk of suicide in patients suffering gender distress. The Cass review concludes that first-line treatment should be a holistic approach utilizing psychotherapy and screening for neurodevelopmental and mental health conditions. Psychotherapy is the first-line treatment approach for any mental health challenge a child experiences, so this should not be surprising. The World Professional Association for Transgender Healthcare, WPATH, is cited frequently as the authority on the most up-to-date and reliable recommendations for the treatment of gender distress. However, the Cass review found that WPATH's most recent guidelines, Standards of Care version 8, did not base recommendations on strong evidence. The review found a circular basis of reference between WPATH and the Endocrine Society guidelines. WPATH helped draft the Endocrine Society's 2009 guidelines, while WPATH version 7 guidelines referred to the Endocrine Society's guidelines. These 2 guidelines heavily influenced almost 20 other guidelines. WPATH's newest Standards of Care version 8 in turn referenced WPATH version 7 guidelines. The Cass review notes, quote, most of the guidelines described insufficient evidence about the risks and benefits of medical treatments in adolescents, particularly in relation to long-term outcomes. Despite this, many then went on to cite this same evidence to recommend medical treatments, end quote. WPATH version 8 cannot be relied upon as standard of care. I urge the Health Evidence Review Commission to complete a formal medical technology assessment of gender-affirming care and develop guidelines that are truly evidence-based. Thank you.
Thank you very much. So I think we have 2 more commenters. I think why don't we hear from everyone, and then if we, like I said, this isn't related to stuff that's on the agenda today. And we've already heard, by way of context, there'd already been this issue raised in a request for us to look with the center's help to look at the evidence. And I believe we're kind of working through with the state government to figure out where this is situated in relation to the legislation that's already passed. So that's kind of the context. I have one question for you, Dr. Cerundolo, just out of curiosity. What's the Do No Harm group that you're part of? Can you tell us a little bit about that?
Sure, it's an organization that advocates for evidence-based, safe medical care.
Okay, thank you. All right, let's hear from the other.
Okay, thank you, Devin. Actually, let me take a step back. I have a statement I'm supposed to read before we take this kind of testimony, so I'm going to read that real quickly. We welcome and appreciate public testimony and understand it's an important consideration for our work, and will listen with attention and respect. Although members may not discuss this comment right now, staff and leadership will discuss it prior to the next meeting. As a reminder, the Commission does not debate whether particular services should be covered for an individual patient based on their individual circumstances. Staff can help connect OHP members with helpful resources. To keep us on time, we'll start a timer for each commenter, which will be shared on the screen. Please conclude presentation when the timer ends. Thank you for letting me pick that back up. Next, we have Dr. Roy Epen. Dr. Epen is involved with Do No Harm and LGBT Courage Coalition. Our search showed nothing on CMS Open Payments database. Dr. Epen, please begin your testimony by stating any potential conflicts of interest you have and state your full name for the record. Thank you.
My name is Dr. Roy Epen. I am an endocrinologist certified by the Royal College of Physicians of Canada. I'm a fellow of the American College of Endocrinology and a fellow of the American College of Medicine. I've been treating patients for over 30 years, and I'm an assistant professor of endocrinology at McGill University. In the last few years, the landscape of gender affirming care has changed dramatically. And in fact, even in the last few weeks, we're seeing changes and more data every day. Multiple systematic reviews have been undertaken in Europe and in the United States. The conclusions have been universally that the evidence for medicalization of the vulnerable children and youth we are discussing is not there. The results from Sweden, Finland, and most recently the UK have resulted in major changes to the affirmative model in many European countries, including Finland, Germany, Sweden, England, Wales, Scotland, and calls for review even in Belgium and the Netherlands, where this original pathway originates. There are even reported reviews from the Endocrine Society, which have also showed that the gender affirmative care are not particularly well evidence-based. So let's talk about WPATH. WPATH, or the World Professional Association for Transgender Health, has been in the past thought to be a scientific professional organization, but has revealed itself to be an activist organization that cares very little for science or the children that they purport to help. Many of the members are activists, and in the recent last few months, shocking revelations have come about from the WPATH files, showing that this organization doesn't really care much about things like consent, because they had a video where they showed that they were talking about consent and said that most of the children that they're dealing with don't really deal with consent, but they wanted to go ahead with the medicalization pathway anyway. In the last few weeks, in the last few days, emails revealed from the Attorney General's office of South Carolina have shown that WPATH itself had done several systematic reviews, up to 12 or 13, and had only released 2 of them because the other ones also showed very little evidence for their point of view. WPATH is instrumental in making the guidelines in the United States because many of their members were on the guidelines committee of the Endocrine Society, and they refer to each other in this sort of circular logic. So that the WPATH people say that, they're the world authority because everyone refers to them. And then the people who use the WPATH guidelines say the same thing. So it's just sort of circular logic. So issues such as fertility and the ability of these children even to eventually experience orgasm have also been dismissed as being secondary to the all-important goal of medicalizing these children and teens as fast as possible. Indeed, in the last WPATH
Dr. Eapen, I'm sorry to interrupt. I think we're, just to be fair to everybody else, I think we're up on the testimony time, but
oh, I'm sorry. Okay.
The points are taken.
Thank you.
Thank you. And finally, we have Mr. Paul Turdahl. Mr. Turdahl is an OHP family member and Oregon resident. Our search showed nothing on the CMS Open Payments database. One moment, please. Mr. Turdahl, if you could state your full name for the record and any potential conflicts of interest you may have and begin your testimony. Thank you.
Great, thank you. Can you hear me okay?
I can,
Yes.
thank you.
Great, thanks. So my name is Paul Turdahl, as you said. I'm a volunteer health consumer advocate for individuals with autism and other disabilities. I'm the father of 2 children on OHP. As of very recently, I'm a member within DCBS of the Insurance Advisory Committee advising on the insurance side of these issues. I'm speaking today to follow up on my testimony in your January and March meetings about this topic. 1 year ago, HERC commissioned a rapid review of gender-affirming medical interventions from the OHSU Center for Evidence-Based Policy. The center's draft report raised significant concerns about the quality of evidence for gender-affirming medical interventions, especially for children and adolescents. The center explained that, quote, "We did not identify any systematic reviews with extractable data on gender-affirming medical interventions among adolescents and youth. Given that paucity of data, we summarize the findings from a single identified systematic review, etc." Faced with that paucity of data, to use the center's words, and the passage of House Bill 2002, HERC staff canceled the contract, abandoned the review, and withheld that draft report from publication. The good news, as you have just heard, is that there are now several high-quality systematic reviews with extractable data on gender-affirming medical interventions that have been published and should really be used to complete your study. Last month, Dr. Hilary Cass from the United Kingdom completed a 4-year study of gender identity services. And as part of that, there were numerous systematic reviews from the University of York. The conclusion of Dr. Cass and our team was, quote, "This is an area of remarkably weak evidence, and yet results of studies are exaggerated or misrepresented by people on all sides of the debate to support their viewpoint. The reality is that we have no good evidence on the long-term outcomes of interventions to manage gender-related stress." In a New York Times interview 3 days ago on Monday, Dr. Cass went further. She wrote, or she said, "The University of York, which is kind of the home of systematic reviews, found that evidence in this field was strikingly lower than other areas, even in pediatrics. I can't think of any other situation where we give life-altering treatments and don't have enough understanding about what's happening to these young people in adulthood." Another comment she made really hit home for me. It's something basically that I think I told you or your staff a couple of months ago. She said, "It wouldn't be too much of a problem if people were saying, quote, the clinical consensus, this is clinical consensus and we're just not sure, unquote. But what some organizations are doing is doubling down and saying the evidence is good. And that's where I think you're misleading the public. You need to be honest about the strength of evidence and say what you're going to do to improve it." That's really what I'm asking you to do. Two things. First, withdraw your endorsement of WPATH 8 because it has not been vetted by you, and complete that medical technology assessment so we can get an evidence-based coverage guideline out there that people can follow and understand the true strength of evidence by your customary standards. Thank you.
Thank you.
Thank you. Thank you all. We appreciate the comments and insight. Certainly important and interesting topic, and we're aware of the context in which it's being discussed, and probably a lot of us saw the same Times article this past week as well. So, and as I said earlier, HERC staff are kind of working through options on what we can do in this space. That said, so there's obviously no resolution we're going to reach today. That said, any questions or comments for the commenters? All right, if not, I'm sure we'll come back to this question in the near future. So thank you all three for coming. All right, we can move on to the director's report.
All right, thank you. So I have a little bit of a long director's report today, longer than usual, so please bear with me. I'll try to keep it short, but feel free to interrupt if you do have questions. First of all, as you already noticed, we're going to start the practice as referenced in our bylaws of asking if anybody has personal interest or conflicts of interest to declare. This would be in addition to what's already disclosed on our website. If there's anything that's more of a direct conflict with something that's specifically on the agenda, like you have a publication or a significant financial interest, that's the time to declare that. We're just going to do it if nobody discloses, that's completely fine as well. Second, there is a project starting up at OHA that's going to significantly impact our work. I want to describe that briefly to you today. As you may recall, Oregon has a special waiver from the federal government that allows the state to determine benefits with the prioritized list, which is a big part of our work here. This waiver will be ending by January 1, 2027. So after over 30 years, that waiver will end. We have a project underway called the OHP Benefit Update to help with the transition. It'll update the benefits structure for the Oregon Health Plan. While this is a significant change, there are a lot of things that will remain the same. Here are a few points. First, no currently covered services will become not covered because of the project. Of course, this group will continue to do its work, but as a result of the project, that's not on the table to take away benefits. This is not a benefit reduction exercise, neither is it a major benefit expansion. There is the possibility for a small increase in the number of services or treatments that members may have access to. Changes to the Oregon Health Plan coverage that result from this project will not take place until January 1, 2027. Second, we expect HERC to continue after that date to serve as a body that assesses clinical effectiveness and medical necessity of health services. Public, transparent processes will remain a priority with ample opportunities for community engagement. As a part of this, the funding line will go away because the waiver will end, and all medically necessary benefits within the scope of Oregon's Oregon's state plan will need to be covered, and that's the same as it is in all other states. While the prioritized list will need to be restructured, much of the policy expressed by HERC's decision will continue in different forms. Throughout this process, OHA's objective is to have two-way communications with OHP members, partners, and Medicaid plans. We'll be gathering feedback on the impacts to Medicaid plans and members, sharing that information to promote transparency in the work, and OHA will incorporate feedback into implementation planning to minimize additional burden to CCOs and providers and support clear communication with members about any changes. In the meantime, here are some of the outreach efforts. There will be a OHP benefit update webpage coming soon. There will be a series of meetings with CCOs, including the OHA/CCO Leadership Policy and Strategy meeting and the Quality and Health Outcomes Committee meetings. as well as meetings with member-oriented groups, such as OHA's Community Partner Outreach Program. This summer, we'll have at least one virtual meeting tailored to the Medicaid CCOs, and at least one virtual meeting tailored to member proxies, which again are groups that represent our OHP members, to learn more about the upcoming changes and provide feedback on the impact. OHA will also convene standing meetings with CCOs in the fall for regular updates and discussion of operational decisions. So that's what I can share today. Obviously more to come, but are there any questions about that for now? Okay, well, stay tuned. Again, we'll have more information coming and we'll be reaching out.
So it sounds like HERC would still exist, but less so for the purposes of determining coverage than to provide kind of evidence-based clinical guidance that's relevant to work.
I'm not sure the exact parameters, but again, a lot of the current policy will remain. It'll just be a new form. The funding line can't exist, and so that just changes the structure of our work. But if a service is not effective today and not effective tomorrow, probably not going to be covered tomorrow. I'll say that much. And again, we're not expecting major changes to benefits, but there may need to be some just to comply with the requirements and make sure we continue to provide good care to our HP members.
Will there be a new committee that will determine the actual benefits, or will that?
Again, all that a little bit TBD.
Okay.
So stay tuned. All right. Next issue is another law change. Liz, if you could bring up the presentation. So in the 2024 legislative session, a bill passed, it was signed by the governor, Senate Bill 1508, and it's related to concerns that members have brought to legislators about quality adjusted life years. The bill affects more than that. I'm going to walk through that a little bit today so that everyone understands the changes we'll be making as staff to the work here. First of all, the bill goes into effect on January 1st. It prohibits the use of quality of life in general measures. That's a term in the bill that's defined. It's basically quality adjusted life years and similar measures, but there's a definition in the bill, but I won't go into that today. By HERC and in the Oregon Health Plan and Utilization Management. At HERC, we're required to redact those sections referencing those from studies under certain conditions. We'll go into those. It also requires our HERC to meet in public, as we are today, prohibits executive sessions, which we have never done, and requires us to follow public meeting laws, which we try to do. It also prohibits us from contracting with a single evidence vendor. We contract currently with the Center for Evidence-Based Policy, and they provided great evidence reviews to us over the years, but they're saying not just one vendor. So, and we have to allow public input on the selection of evidence-based vendors. It also adds some language about research practices and evidence reviews, which we'll go into as well. First of all, just a little disambiguation for those less in the clinical research realm. Quality of life, QOL, is not QALYs. Quality of life are self-reported patient-important health outcomes, measurements that assess a person's perception of their own condition and well-being. Often it's a little questionnaire people fill out. Common areas of focus include functional status, psychological or emotional state, symptom management, pain, and it's a commonly used and very important outcome in a lot of the work we do in this, on this commission. Not affected by the bill at all. The quality of adjusted life year, on the other hand, is a measurement that combines both the quality of life and duration of life, or duration of the benefit resulting from a medical service. They allow for comparison of cost effectiveness across different health interventions. So you can compare the impact of a vaccine versus a back surgery, even though they're very different impacts. When used without proper caution, depending on how how they're used and modeled, qualities can and do and have resulted in lower scores for anyone who will not return to a baseline of perfect health. For example, older people, people with disabilities, their conditions will tend to be weighted lower on those scales because not as many years, or the quality of life according to this calculation is already diminished. There are some other concerns about quality adjusted life years. They use broad population survey data about the perceived impact of disability. So, as an able-bodied person, my perception of how much it would impact my quality of life to have a certain disability may be different from somebody who actually experiences that disability. But the qualities tend to be based on these population level surveys. It also uses a single number for conditions with highly variable health impact. Some of the testimony was about autism, which can be highly variable. But there's a single number that's used for population level data. It can be used in ways that are discriminatory. As I said, it'll value services that improve health or reduce disability over many years. And it'll value a year without disability more than one with disability on average. And I think you can see how that makes sense from a perspective, and also how it could be used in a way that is discriminatory. The original prioritized list used a very similar concept to rank the lines. There are some vestiges of that in our ranking methodology that was used to rank the current list. We did an analysis of the services that are below the line and recent appearances of qualities that are meeting materials. We reported to you all on that in late 2022. In most cases, the reference we use is supported expanded coverage. There were just a couple that were different. But nonetheless, because of those concerns above, the legislature wanted to ask us not to use this measure. So here's what we plan to do. The first thing is to redact, report, and insulate. So we will be redacting qualities from any research articles, including the intermeeting packets. And we will not reference those in our staff summaries. So again, if you have a 50-page article and there's 2 sentences about quality adjusted life years, those will be blacked out. And we won't reference in the staff summaries. The rest of the article will remain available. We worked with the legislature to find language that was mutually agreeable to allow us to benefit from the quality of life and the other health outcome data that are in those articles. We will also do reports going back farther in our history for references to quality adjusted life years and those vestiges I mentioned in our ranking methodology. Those will become part of our biannual report to the legislature that will be completing next year. And that'll become an ongoing practice to report on those. In addition, as I said, we'll be contracting with another evidence vendor. Although these concerns were raised by disabilities advocates, our plan is to hire an equity consultant that'll meet this requirement, who can give us just another perspective on health equity issues in our work. Maybe ask us some questions that our team hasn't, help us think about some things in new ways and improve our work. So hopefully it'll have a lot of benefits in addition to the quality related and disabilities related work. And finally, we'll be starting up a disabilities health advisory panel, begin meeting next year. We'll probably do some preliminary recruiting and maybe a listening session to kind of see what the areas of interest are this year. And there's one topic lined up that will likely be discussed there, as well as in the BBBS subcommittee and on this commission. Next slide. There's a section on the bill that talks about research practice requirements. And I'm going to read this because it's a little bit of a mouthful. There's a lot of language here. HERC must evaluate a range of research analysis, including peer-reviewed medical literature, that A, studies health outcomes that are priorities for persons with disabilities who experience specific diseases or illnesses through surveys or other methods of identifying priority outcomes for individuals who experience the disease or illness. Studies subgroups of patients who experience specific diseases or illnesses to ensure consideration of any important differences in clinical characteristics applicable to the subgroups. And C, considers the full range of relevant peer-reviewed medical literature and avoids harm to patients caused by undue emphasis on evidence that's deemed inconclusive of differences without further investigation. So a lot of language around research practices, outcome selection, what is a priority, what are the important outcomes, which are things we already take into account for every issue that we look at. But we'll be looking for ways to improve this, to get feedback from that panel as well as others through our other meetings on how we can do better. So that is one of the topics. We'll go to that panel, we'll see what else they bring, and of course, any decision will come through this commission. So we'll be holding several listening sessions this summer and fall. We'll be recruiting members. If you have people to suggest, especially people with disabilities, please send them our way. We'll be putting out a formal recruitment, which you'll all see, and then we'll work on a charter and a meeting structure. And of course, we'll keep the commission informed along the way. Like our behavioral health advisory panel, our oral health advisory panel, and our genetics advisory panel, this will be a staff advisory panel, so it won't be a formal subcommittee. They won't have minutes or votes, but we as staff will work with them, learn from them, incorporate their perspectives into our recommendations that we bring to you. Any questions, thoughts, concerns, comments about anything?
I have one question if you go back a slide. So the last, part C there.
Yeah.
So consider full range of relevant peer-reviewed medical literature. Whenever, it looks like if we ever have inconclusive findings or clinical differences, like we have to do further investigation. Am I interpreting that right? So a lot of times there may not be clear evidence one way or the other, and so, but generally we're looking at quantitative data. Are we supposed to, if we have inconclusive evidence from the medical literature, what are we to use additional types of evaluation mechanisms?
That's what
it sounds like.
It has the word undue in there. We don't want to put undue emphasis. What do we do? That's something we'll want to discuss with that panel. So when we as staff saw this language, we thought, we do a lot of this already. How can we do better? It's an opportunity to build relationships, to build trust, and to learn from our community members affected by disability.
So this could also be like qualitative methods?
Potentially, I don't know. I mean, they mentioned surveys farther up.
Surveys.
There may be some wonderful ideas that come out of this.
Okay, cool.
How much of that we'll be able to
But we're
implement?
still looking at published peer-reviewed medical literature.
Yes,
Could be qualitative or quantitative, but that's considered the
Still-
full range of that type of literature.
still peer reviewed,
Not gray literature, yeah.
yes.
I mean, another way to read that sentence is which is how I would interpret it, but I'm not sure if that's what they meant by it or not, is that, the absence of evidence is not the evidence of absence kind of thing, so.
And to look deeper.
Which is a point that, gets confused a lot, right? So when you have inconclusive evidence, that can be interpreted as there's not evidence to support X, Y, or Z. But it really just means there's inconclusive evidence. So that's how I would interpret, but that I don't know if that's what they meant.
But and that's what we're gonna work out and
But that would be good for us to think about. I think we should do that anyways. Because then you're really talking about the values and preferences and costs and stuff like that. And that's where, if you have literature on values and preferences, I think that kind of stuff can become important.
other thoughts, questions, anybody online? All right. Well, again, more to come on that. We'll keep you posted on updates, especially about those listening sessions and advisory recruitment.
And Leslie
Hey, Jason, this is Leslie. I'm sorry, I'm a little bit late on the unmute. I apologize. I just wanted to say I'm really excited about an advisory group. I think that that's really a great way for the HERC to be taking in advice and direction from people with disabilities, because after all, it's their lived experiences. And so they're the ones that can truly inform the work. So I'm really excited about that aspect. And I really appreciate that connection between staff and that potential work group. So thank you so much.
Yeah, and Leslie has volunteered to serve as the liaison to that panel, although her term on HERC sadly will be ending next year, so there'll be a transition as well. All right. If there's nothing else on that, Daphne, can you give your outreach report?
Sure, I'm happy to. So, as you know, we've been ramping up our outreach and engagement program over the last year or so. I was hired permanently in September to do this work. And one of the things I've been doing is attending so very many rural Oregon local community health meetings, making connections, reporting on commission activities. I've been telling the tales of your good works to local and grassroots health organizations. And every time I give one presentation, 3 more people ask me to give a presentation to their local grassroots group. So it keeps growing and growing. And these times I've learned some really great things. For example, when we were prepping for the March listening session, we had an OHP member suggest a topic, and which is not unusual, but this one was at the urging of a CCO. So to me, I thought, wow, engagement works. People are in general amazed they can take a concern to the actual commission. A lot of folks have expressed to me they thought the CCOs were in charge of benefits. When I hear a concern outside of HERC's control, I do what I can to connect those who I can help. And in the meantime, I'm building relationships so that people know they can come to the HERC with concerns that we can address here. If there's anything specific you want me to convey to any part of the people that I'm building networks with, just let me know. I'll put my email in chat if you don't already have it from the years of me bugging you. Thank you very much.
Yeah, so that's really important work, Daphne, and connecting that lived experience, on the ground knowledge. I mentioned earlier the nature of our healthcare delivery system. She's hearing a few things about that. Hopefully that will better inform our work and connect it to the medical literature. All right, and then Ariel, you want to report on the listening session and the breast cancer update?
Sure. Quickly on the breast cancer update, some of you may have been aware that there was a, the USPSTF just updated their breast cancer screening recommendations. They now recommend mammograms every other year starting at age 40, which is a decrease in the age. We looked at our current guidelines. We reference USPSTF and the HR, I forgot this in BBS as well, Jason. The Health Services Administration,
So,
Women's.
yeah, the Women's Preventative Services Institute,
WPSI.
WPSI.
Yeah, so, and they already had recommended coverage of mammography starting at age 40, and we're silent on frequency. So our coverage should align with USPSTF. And then as Daphne was alluding to, we're having listening sessions. We're having about quarterly, where members of the public can come and talk to HERC staff about concerns. In your packet, there should be the report from the March listening session. We heard about 3 topics. One was regarding circumcision, which we're going to talk about a lot more in detail and a little bit later in the meeting. The next was about Ehlers-Danlos syndrome, which is a genetic disorder in which your connective tissue is too loose, too lax, and results in many injuries. We currently don't cover the syndrome because there is no treatment for the actual genetic disorder, but we do cover the physical therapy and other things that these folks might need. And one other piece of that was the person who spoke on this topic also wanted some coverage for POTS, which is postural orthostatic tachycardia syndrome. This is a condition that also is seen like in post-COVID syndrome, and still staff is just looking at preliminarily, we think we cover all of the recommended treatments, but we'll make sure that we look at that thoroughly. And then the third topic was coverage of crowns and root canals. We've heard this over and over again, that there's a lot of community concern that we don't cover crowns and root canals. We actually do on the prioritized list. They are in the funded region. There was a specific legislative action taken that took away funding for that, which is beyond our control. It's more of a higher level policy decision, but we have let OHA leadership again know that this concern was raised. Any questions about the listening session? We are planning to have another one in June. We're planning them, as I mentioned, quarterly. So if you do hear of any concerns, other things that you think, particularly a community member or a patient or a caregiver would benefit from this, please direct them. HERC.info is a great address, just a generic email address to refer people to.
If somebody comes to a listening session and testifies or brings something up, do they get feedback afterwards on what happened?
That's an excellent question. We should close that loop.
Oh, Daphne's raising her hand.
Oh, Daphne,
I follow up. I follow up.
thank you.
Nice.
Thanks.
Yeah.
And also we do get a lot more questions. People bring up a lot more things they would like to talk about, and Daphne has done a really good job of reaching out to them. Many times it's things that we don't actually have in our purview, and then she tries to steer them to the right place at the state. You know, we have a convoluted bureaucracy like most states do, so.
I consider myself a resource broker.
Yeah.
Nice.
This is Leslie. I had a question about if the staff felt like we needed to have some sort of a public-facing procedure about what to expect when you attend one of these and speak up and about what may or may not happen with your topic. I know that HERC staff have done such a great job like creating those statements that happen before people give testimony and things like that. I'm just wondering if it makes sense to create something that people can look at, since the listening sessions are a different venue than the HERC.
Daphne, do you? Daphne has done a lot of hands-on touches with folks, you know, kind of prepping them. And then we actually are still working on our process. We had one listening session where we allowed people to speak up and make comments, and then that led to some difficulties. And so we have kind of got backwards on that. So we're still kind of learning as we go. Daphne, any other thoughts in that area?
Yeah, I just put our brand new webpage about listening sessions in the chat, where we've laid out some of those things for people. People who are suggesting topics to us get a very, as Ariel said, a personal touch. I have Zoom or team meetings with them where we thoroughly vet everything they're thinking. And then the link didn't work for you. Huh, that's weird.
I'm trying it again.
I'll work on that, Chris. I'll email it to you as well. So we work together, and then if it's something that we can't help with, or another part of Oregon's government can help with, then I do a warm handoff to them. I'll take them right to my favorite ombuds person or another organization that can help.
Great.
And at the end of each session, each person, I try to kind of bring forward next steps if we, you know, at least what preliminarily we think would be the next steps. And then Daphne kind of follows up.
Yep.
Oh, sorry, go ahead.
Oh, I tell them in follow-up conversations about, you know, your when it's going to happen, you know, if it's going to be on the agenda, is to give them another chance to come and talk. If it didn't make the agenda or isn't coming, we talk through that, and I give them other avenues for their issue.
You know, one thing that I don't know if this is feasible or doable, useful, feel like selfishly it would be for me. It's like an org chart for Oregon, or something.
It would kind of be a Mandela.
Like three.
Yeah, maybe it's not feasible, but just to understand, for the public to understand, I'm including myself in the public, just, like, who does what in terms of healthcare policy
That would be good.
in Oregon. I don't know
It's
if there's a
very
vis-
messy.
Very messy. It may not be feasible. If there's a visual way to represent it in some way, it would be useful. But,
I think that could help in many different.
yeah, I mean, I feel like I should learn that.
And some
after
places
doing
where
this for 6 years.
Healthcare can't get through,
Yeah,
you know, some populations are isolated.
Yeah, I mean, it's a
Different
great
types of
idea, and
events, too.
staff can kind of, we'll talk amongst ourselves and with
Yeah.
other folks to see, they may already exist somewhere, or
I mean, it may just be a big blob.
it may be.
Right.
In the organizations that I've been giving presentations to, when I talk about the OHA's ombuds team, they're just floored that there's an organization or a state group that can help them through their situations with OHP. They didn't know.
Yeah, sometimes it takes that, like looking at a chart might not tell you where to go. You need to talk to an ombudsperson because they can elicit the information. They
Mhm.
get you to the right person because they have so much experience. Sometimes it's not immediately apparent what the core issue is.
Yeah, that makes sense. Great. Well, thanks, Daphne, for.
Yeah, I'm having so much fun. And Chris, I sent the link to you by email.
Okay, I'll look, thanks.
Yeah, and the link that Daphne posted, if anyone has any comments, and this is
Mhm.
a work in progress, but Daphne's been really working on trying to make our webpage more accessible and have more stuff. So if you go there and you're like, well, this didn't work, or hey, why did you do it this way? Let us know.
It's in English and Spanish, so happy to take your comments.
I can just give one like half comment potentially since you're really asking. I recently learned a term and I hope I get it right, but it's with the educational system, like universal communication or universal accessibility. So
Universal design?
Universal design.
Yeah.
So I would look into that as far as an interface, universal design. That might, you might be able to have more ideas.
It was actually originated for disability.
Yeah,
but it's-
Okay.
it's
Yeah.
really good and yeah.
And who was that suggests, I'm sorry, I don't hear recognize your
Lisa
voice.
Cruz is.
Lisa
Oh,
and
hi,
Chris.
Lisa. How are ya?
It's a group effort. Hi, I'm like in the corner here.
Okay, thank you.
I
Appreciate
can
it.
send you, I can send you some starter stuff. I looked at it when I was doing my.
Sure, I'd love to see it. We are governed by our IT program, so there's some limitations to what we can do, but I would absolutely love to see it.
Yeah, it's a conceptual framework, so I think you're probably already doing a lot of it. It's more like principles.
Getting a
Okay,
little
perfect.
worried about Time.
Yeah.
Aw, this isn't Daphne's show?
No, it always,
Shoot.
it should be, but,
It should be.
Oh, very well.
Well, we can move on to the VBBS report. So the Budget Benefits Subcommittee met this morning. We heard, if you remember back in January, I told you that we had been talking about vulvodynia, which is a painful condition of the external genitals. And that it is, the best evidence for this is treatment with either pelvic floor physical therapy or surgery. And we've been involved with the OHSU Vulvar Health Clinic. There was the idea that we should move toward coverage in January, but there was questions about coding. So I've been working with the Vulvar Center and we had kind of clarified all the coding issues. And so what was decided this morning was, basically it was in your materials, that we will be covering surgery and physical therapy for 3 procedure codes that are vulvodynia related, with the acknowledgement that they're not the words that are being used by gynecologists, but they're the codes that they use. We also talked about dyspareunia and vaginismus, There was some discussion at BBBS this morning, so vaginismus is sort of an involuntary contraction of the musculature in the vagina, usually be after lots of, someone who's had a history of painful conditions or they've had trauma. And the vulvar clinical folks use this as the diagnosis code for all the pelvic physical therapy that's done after the surgery. And they requested that we add that with the same package. There's a lot of concern at BBBS this morning that vaginismus is a much broader topic. And so staff was directed to kind of just take that one piece and have some more consultations with the vulvar specialists about whether we add vaginismus to the same line of the vulvodynia with a guideline saying that's just there for treatment after vulvodynia surgery, or whether we entertain a more broad coverage and what that would mean and what types of treatments and patients that would be involved. Anyone have any input on that topic or any staff direction?
So is it tabled right now? I mean, it's not.
So the
tabled, but-
vulvodynia,
Yeah.
the surgery and the physical therapy, the recommendation is to go ahead and approve that.
Okay.
It's
But
the
then the vaginismus
vaginismus, which in your materials was basically just consider.
Consider, yeah.
So that was tabled until a
Okay.
future date.
Okay.
Okay. And then we had a lot of straightforward stuff, big long table of things, some minor guideline note changes. If you'll remember, after our discussion of adding coverage for hemorrhoids, Dr. Pedraza had volunteered to do some just kind of fine tuning of our codes, and actually the recommendation is actually kind of taking away some of the codes that we were going to add, as well as adding a couple back to the uncovered line that he thought would be used there and under exception. And then the oral health advisory panel report, which you heard last time, but we couldn't vote on because of some, the technical kind of public notice that was approved without any changes. And then we also added a diagnostic guideline, just basically codifying what is our policy, which is that MRIs of the brain and spine are covered for MS. That's our policy, but there's some confusion because there's other MRIs about brain and spine for other indications, and we don't list MS as covered, so yes. Just to clarify, it's our current intent clarified. Any questions about that? Okay, then we talked, CMS is releasing their HCPCS codes every quarter, so will be frequent times where we'll have to bring up new codes. There were 5 codes that I had pulled out for discussion, one of which was actually in a topic later. And actually, having looked at this as I was starting to kind of put together notes and minutes, I realized that one code that was approved for adding to a line at the meeting this morning, we actually should not approve. So I just need you to amend the VUDS report and not approve one code, and it's because it's for the CMMI program, which is a very specific Medicaid-only program, and I missed that little clause in there. So it is the G0519, and it's management. These are all for a new CMS model for dementia care, but it's Medicare specific, and programs have to apply to CMS, and it's very, it's a thing. And so it would be G0519. We are not going to put that on the dementia line. I apologize. I caught the other 20 some.
Yeah, right? Yeah, don't worry about it.
Missed that one. Sorry. Going back to the report, we looked at our continuous glucose monitor guideline and did basically, it was all like kind of consent house coding changes, but there was enough that I brought it as a topic. The one main change in intent is that we added coverage for glycogen storage disease type 1A. There are 5 patients in Oregon under OHP that have this. It's a condition where people have frequent hypoglycemia, low blood sugars, even though they're not diabetic, and they need these monitors. So we added that as a specific covered diagnosis for those 5 patients. And then we pulled out, there had been some kind of scrambling of initial approval criteria and reapproval criteria, so we kind of took out the reapproval and made them the same. And then there was some just, we had had some comments from So the current coding, pairing, and the intent is that anybody who has diabetes, regardless of the cause, who's meeting all the criteria, would qualify for a CGM. The CF clinic brought up concerns, and many people with CF also develop diabetes because of how the disease process progresses, that these people need CGMs. And they would use the diagnosis diabetes due to other conditions, and then people who have diabetes because of long-term steroid use or other things, who have diabetes due to medications. So we just clarified that type 2 diabetes includes all of those conditions.
Okay.
Any questions about that? And then we went into some new topics, basivertebral nerve ablation. This is a procedure for low back pain. There was recommendation for continued non-coverage. Of note, it was a 9-1 decision, it was not unanimous. Percutaneous tibial nerve stimulation. This is a procedure, it's a little nerve stimulator to the shin to help with overactive bladder syndrome. Kind of think of it in terms of acupuncture, that kind of, it's stimulating a nerve who has another root that goes to the bladder. And there are multiple, granted small, maybe not well-conducted studies, but multiple randomized controlled trials of this does help. And currently the things that would also be covered and helpful for overactive bladder are medications that have pretty significant side effects. And there's not a lot of other things. So the decision was to add coverage within the guideline. And we talked about deep brain stimulation for essential tremor. So essential tremor is when somebody has a shaking of a hand or both hands. It can be a very minor thing, and it can get to the point where being so severe somebody can't do their ADLs. Deep brain stimulation is a neurosurgical thing where they put in an electrode into a very particular portion of the brain and to stimulate it. The evidence shows that about 60% of patients have really significant reduction in their tremor. The discussion was that this is not going to be overused. It's a brain surgery, and people need to be very severe. We added it with a new guideline, which basically is just the CMS coverage criteria. And then X-ray emotional analysis for low back pain. This is standard X-rays, are usually 2 views of the back. This is a series of multiple X-rays, so you can kind of see how the back is moving. The back as someone is moving. There's no specific codes for it, HCPCS or CPT, and there's really no evidence that this results in any particular improved outcomes. So we adopted a new guideline that basically says that we don't cover this, and that there is no coding so that we can't put it on like our guideline number 73. Any questions about any of that? We talked about actigraphy, which is a motion sensor that usually can wear around the wrist. This is a standard one piece of the data that you get from a polysomnography or a sleep study. It's also used independently to look at other sleep conditions, but there's really no evidence that it helps with diagnosis. There's other things like sleep logs and just other things that are very accessible and inexpensive. And so we did not cover this, and we added the code to 9173. And then we talked about next generation sequencing for cancer, that tests that are done on the blood. So I'm sure you remember, we had a cancer genetic work group that got together last winter for multiple meetings, and we added coverage for next generation sequencing, which are these large gene panels that look at cancer. They try to find what mutations driving the cancer and helps tailor therapy. We adopted a new guideline for that last spring. That guideline doesn't specify whether the sequencing is done where the sample comes from. And there have been questions from the CCOs because there are 2 types of places that you can get that DNA from. One is directly from the tumor, so like a biopsy of the liver or whatever organ, take out the tissue of the tumor and then run the DNA. That generally by the NCCN and other guidelines is considered preferable. And then there is another method where you draw someone's blood. Think of it as analogous to when we test pregnant women to look for fetal DNA. They can find tumor DNA in the blood now. And this is recommended by NCCN if you aren't able to get a biopsy because of the patient's health status, or you do a biopsy and you don't get tissue. And so we added wording to our guideline with those two clauses. That was approved unanimously. There was also sort of a unanimous request that we bring this back next May, because this is a light speed changing field. And the blood test actually is quickly being moved to sort of first line rather than subject someone to the biopsy. It's not there yet, but a year is infinity in terms of genetics. And also our next generation sequencing, the specifics that we have in our guideline is probably gonna be outdated in a year. So you will be seeing updates.
Is there a way we could have a craft language that would connect it with something that does update more real time, like we have
That'd be
with
lovely.
the breast mammography?
Yeah,
Just a thought, just that's where I would go with, because it's just changing so quickly, and I would hate,
and there are
Cancer
50
stuff is
state
scary.
Medicaid programs that would jump up and down in happiness if that
Yeah.
existed.
We hacked did that with the FDA companion list. It's like a sort of part of that. It's better than nothing.
yeah,
So the FDA companion list is when the FDA approves a new drug, a cancer chemotherapy, and it's for a mutation, they kind of say you need to test or prove someone has this mutation before you give them this drug,
I see,
or prove they don't have this before you give them,
fair enough.
for things that don't work. That is a very highly imperfect thing.
So how does this relate to staging cancer? Is it by definition stage 4?
Enough of that.
No, and in fact, like with rectal cancer, they do it as early, or earliest stage as possible, because they're actually finding a few of the treatments for rectal cancer for like stage 1 rectal cancer cure the cancer without any surgery. So I mean,
Takes a while for the cells to take hold and form another tumor.
yeah. So this is kind of unrelated to stage, because regardless of the stage of the cancer, you're really looking at which chemotherapy agents, in the old fashioned, like
So the-
giving platinum or whatever.
This isn't supplanting the standard diagnostic approach for.
Right, so you might still do a PET scan or a full body CT and find mets, but then if you want to treat it, you need to figure out which of, you want the EGFR
Right.
driver drug for whatever, or,
It's more changing, instead of focusing on origin.
Yeah.
It's more focusing on these genetic tests in terms of treatment. So it'll change how we talk about cancer sort of verbiage, but not necessarily staging.
Yeah.
And at least for Medicare, it has to be pretty advanced before you can get these tests. So
right, but our work group was really specifying that, like with the rectal cancer diagnosis, like that's turning treatment on its head.
Yeah.
They're not doing surgery anymore.
Yeah.
And then, there's all this stuff out there, like the utopian future where
You do
just-
your liquid biopsies as your.
As a screening.
Mhm.
and then, yeah.
Right, yeah. I mean, that's where I think anyways, that gets it. I mean, you wonder about the overdiagnosis possibilities in that circumstance as well.
Yeah, so
Well, it's all probabilities, right? Because then you can also see whether they're active or not. And then there's all this.
well, no, I
stuff
think
about
Deborah was referring to the blood test. There are things in clinical trials right now where a healthy person with no signs of cancer is getting a screening.
Yeah.
And these people, sometimes they find a cancer signal, but then you have to figure out where it's from and whether it's real. What we're talking about with this cancer, the next generation sequencing is you have a big met or big something in your lung. We already know that there's something
We
there.
have
You want
lung
to guide
cancer, but
treatment.
we need
You want
to
to guide
know
diagnosis
markers
for
of it,
treatment.
yeah.
Yeah,
It's still related to that gold standard of biopsy, but it's still moving away versus being predictive or using probabilities to treat.
well, I mean, it is predictive in terms of like, if this lung cancer has EGFR as its driving mutation, it's more likely to actually have a good response to, and there's,
Yeah, it's,
I don't mean to derail us, I just would want, if there's ever a possibility to find some kind of authoritative source that is collecting all the emerging data
I was just at a national meeting of
Yeah,
Medicaid programs and that was everyone was screaming about
for
this.
that, right? Okay.
And biomarkers in general, which are, this is kind of one piece of, it's the Wild West, but it's also really exciting, but yet it's also maybe overused, there's all those pieces.
Thank you for taking the comment.
Any questions about the decision or the?
We
talk-
value you, we wanna keep you, not overwhelm you.
No, not overwhelming me. Leadless pacemakers, we continued non-coverage. Medicare still says that this can only be done with evidence development, and I think the group this morning had a lot of concerns about the adverse events that happen with these, and then a lot of questions about there's no plan on how to take these out or change their batteries or anything. So until this technology is better developed, we're gonna continue non-coverage. We are also gonna continue non-coverage of perirectal spacers for prostate cancer radiation. This is kind of falls into that good idea but didn't work out. If you can move the rectum a little further away, get a little bit, you might be able to radiate the prostate and would not hurt the rectum, but it doesn't actually turn out to be helpful. And then periurethral injection of bulking agents for urinary incontinence, this just doesn't work. So continued non-coverage. We also talked about percutaneous ultrasound guided tenotomy. This is a procedure for sort of chronic inflammation of the tendons. It's been proposed for use in multiple different joints. There's no code for it, and the evidence is that it's probably not helpful. And so we are adding a new guideline, basically, kind of the theme of the day. There's no codes, but we don't want to cover this, however it's coded. So any questions about that with the one modification of that one code placement? Because the last topic there was no decision on, but there's a lot of meat to talk about. So maybe, do you want to approve, or do you want me to hear this, then we can talk about the circumcision and then.
Well, let's, you wanna just approve this and then talk about circumcision?
Can I just ask about trigger finger? Was that a thing that was?
Oh, that was just straightforward.
Was it
Yeah,
straight- okay, sorry.
we cover,
Just wondering
apparently
if
we
any
cover
changes
every
with that.
finger but the index finger. That was a mistake.
Okay.
So,
Alright,
I'm sorry,
okay,
actually,
good.
that was an errata, so that doesn't even get
Okay.
approved.
Oh, okay.
That just is us telling you it
Still
got fixed.
figuring out this giant PDF, so.
Yeah, so I'm sorry, I did not mention that in the staff report, but we do find things that are so obvious that they're obviously not your intent.
Okay, good.
That staff just go ahead and fix them, but we obviously let you know. And then if you don't agree, obviously,
Okay.
you can definitely bring that up. So that's what we call the errata.
Okay.
And that was, I think the index finger is just as
It's like
important as all
added
your
from
other
a
fingers,
lot
and I
and-
think that was just a mistake.
I don't know, I'm voting for the pinky.
So,
Okay,
and then
Index
actually,
finger gets all the
I
attention.
mentioned this morning, but I forgot to mention it to you, there was one thing that didn't show up in your errata that we just fixed, and that was, we apparently took vitamin D testing off all the lines where it's actually appropriate,
Oh, no.
So we put
Okay.
that, but it's only still on the limited ones.
I'd be very glad if you got rid of the vitamin D testing.
Oh, no.
We only, we
Yes.
actually only cover it for, but it's things like osteoporosis, chronic kidney
Right.
disease, people who have malabsorption, we don't cover it in.
Risk factors.
Yeah, so
Okay.
we get reports of things, when things don't match and, just the big computers in the world tell
Okay.
us, do you wanna look at this? And vitamin D is always at the top of the list. And it's paired with everything, mostly just annual physical, that kind of thing. We don't cover it routinely.
Cause it went off, yeah. Was for a while.
Yeah, we did a big trial to see if vitamin D helps with anything.
Right.
But anyway, so
Question. Ariel, on the dynamic x-rays, is it under guideline 173 or?
No, because there's no codes for it.
Right,
And it
so-
has lots of different names.
Okay.
So we've made a little guideline just saying this under all of its names is not a covered service.
Okay, and the guideline will be located where?
I think it was a diagnostic guideline.
I'm gonna pull that up right now.
Okay, just so that I can direct people.
It's
It will be,
it's a movie.
Am I not looking,
Oh,
oh, no, I'm looking at active degree, I'm sorry, emotional, yeah, sorry. It would be a diagnostic guideline in the prioritized list.
Okay.
Yeah, and it's sometimes called kinematic analysis, and then we also figured there might be other data sources for testing.
Okay, so why don't we vote on everything?
There was no decision on circumcision, it was a really an open discussion, so there's no thing for you to approve for that. And since that's kind of gonna be a chunk of time, I thought it might be worthwhile.
All right, so does anybody want to move to approve the
Modified.
the modified BBS report?
I'm moved.
All right, and I guess we formally vote, Daphne. So if you're online, just put it in the chat and
In the room, just verbally.
yeah, verbally.
Aye.
Aye.
Aye. Okay, everybody said yes here.
Aye.
I'm counting hands because Daphne's having some technical problems.
Oh, okay.
It looks like the motion passes.
Okay. All right, now we get to talk about circumcision. We were supposed to start the next thing at 3, which we won't, but maybe we'll try to be
Well, I
on for
think
the next.
we got really good direction
Yeah.
about where this group is interested in, or where VBBS was interested in going with circumcision.
Well, I was gonna say, I think even if we start the next thing at 3:15, I think we'll be okay.
I don't imagine you're gonna really object to where they,
Okay.
with their direction.
Hard stop at 3:15.
Yes, hard stop at 3:15. So circumcision is the removal of the foreskin or the sort of extra tissue at the tip of the penis. It's typically done in newborns, neonatal, but neonatal stretched a little bit to like 6 weeks, maybe 8 weeks old. At that age, it's done in the office with local anesthesia. It can be done on older boys. Generally, they have to go to the OR under general anesthesia, and then it would be, normally it's done in older boys for medical reasons. We do cover it for medical reasons, and there's a whole guideline on the prioritized list of about all of the things. That still have PTSD from, this was like 10 years ago. I worked with a pediatric urologist, and we wrote the penis guideline, but I think that the computers at OHA or whatever it was called then, like about burned up, because I was looking at like boy porn. It's not, it was just more like conditions, like, anyway, I think somebody actually got hold of me like, your search interest,
Oh,
your
yeah.
search terms.
Oh, wow.
But it was all medical, it was all like, you know. Anyway, so we do cover it for a variety of what pediatric urologists would consider very appropriate medical indications. Many parents or guardians elect to have their boy circumcised mostly for religious reasons. There are certain religions that feel this very strongly that this is appropriate. There are also different social groups, et cetera, that feel. There are also groups that and different societal groups that feel that this is actually really inappropriate and wouldn't choose to do this. This topic came to us from a listening session by a couple of people who are advocates for the Afghan, the folks who have come to the U.S. as part of our whole refugee program. This is culturally it's a huge cultural preference of the Afghani population. And many of these people don't have access to it when they're younger in Afghanistan and they're here. And then also in the Afghani community, it's normal to have this done or considered the best practice to do it around age 4 or 5. And they have requested that we consider this and basically has a huge impact on their boys, including not being able to find partners later in life if they're not circumcised, et cetera. We have never covered circumcision as part of OHP, finding that it is a cultural or religious practice rather than a medically necessary practice. Last time we reviewed this was in 2018. And at that point, we looked at so the CDC and the American Academy of Pediatrics both recommend circumcision as a way to prevent HIV. That's based on 3 large randomized controlled trials that were done in Central Africa that showed a pretty significant reduction in HIV transmission, but in countries that had rates of HIV as high as 30%. It's unclear how the results of those studies would translate to the Oregon population, which has a luckily very dramatically lower HIV rate. Circumcision also has been shown to prevent transmission of other STIs, again in high STI transmission populations. And then there is a reduction in febrile urinary tract infections under the age of 1. If you do have febrile urinary tract infection or visceral reflux, which is basically urine kind of going back toward the kidney, those are some of the conditions that we allow circumcision for in our guideline. And then the evidence that was additionally reviewed showed that there is a reduced rate of balanitis, which is an inflammatory sort of condition of the foreskin, but it's an incredibly low prevalence condition. It reduces it in half, but from 0.0056 to 0.0025. So, very, very rare, very high number needed to treat to prevent 1 case. There are 16 states that currently do not cover circumcision. CMS has clarified to the states that they may cover circumcision if they deem it to be medically necessary. We aren't allowed to cover something for cultural reasons, but CMS has said that there is enough, if a state chooses and finds enough evidence of medical benefit, they can specify that in their state plan. Currently in Oregon, HealthShare, which has multiple CCOs, mostly in the Portland metro area, is covering this as part of a business decision that they're using their own funds for, and there may be another CCO. I think there is somewhere else in the state that covers it, but the other CCOs are not. There was looking at some recent studies looking at Medicaid states. 2 states, Colorado and Florida, used to cover it and then they stopped covering it, and then they looked. Basically, if you cover it under Medicaid, you'll have more people getting circumcisions, and if you don't cover it, you'll have fewer. There's a bigger drop in Black neonates not getting circumcised than whites in that situation. So we had a very robust discussion. I think people were really thoughtful and had lots of really interesting things to say. There was a lot of concern about the data on STI prevention really coming out of these high prevalence countries, and that not being really, it wouldn't really inform our decision on this. There was acknowledgement that there are health disparities in Oregon, but that circumcision doesn't really reduce clinical outcomes, although it may reduce like the disparity in who can get a circumcision and not, but it was kind of like, well, that doesn't really make a difference in your health, so it's more of a, whether it's fair or not kind of thing. Private payers do, in general, cover circumcision for neonatal folks. And so there was some concern about the equity of people who are lower income not being able to access this. And again, some pushback, well, it doesn't seem to have a lot of clinical benefit. There was also some concern about the lack of uniform coverage with CCOs, but also acknowledgement that CCOs can make policy decisions. There was, where the group really ended up was directing staff. There was a high level of discomfort with the question even. I think VBBS was unanimous that they didn't feel that the health benefits outweighed the health risks, because there are risks to circumcision. There are complications.
In which population? Newborns?
Both. In the older kids, we didn't even really discuss that because of the risk of general anesthesia dramatically outweighs it. In the neonatal population, VBS this morning felt like the benefits didn't outweigh the risks for neonatal. They felt that this would be something that might be considered because of cultural reasons, but that's not really where HERC is sitting. And that if we want to take this up, we would need input from OHA or state leadership on how to conduct that kind of a decision where there's a lot of values and preferences that would drive it, and cultural decisions and equity decisions. And there was a need that was expressed this morning for a bioethicist or similar kind of person to be available if we're gonna discuss this. So I think in general, the group this morning felt like if there was, that looking at circumcision for cultural reasons is not in the purview of the HERC, but might be in the purview of other decision makers in the state, the legislature or other, high up sort of policy making folks. And that would be some, I think the HERC would respect that if if it's as a policy decision, policymakers decide something. If there is not that sort of decision level that can be made, if policymakers really want the HERC to weigh in, we would need that decision-making framework and bioethicists and kind of really delve into it in that direction. And then just kind of reflecting back to the group, I noted there are other topics that are kind of in my to-do list that are somewhat similar, where there isn't really evidence, but there might be really strong more psychosocial, cultural, whatever reasons. And I think bigger than circumcision, this whole kind of bucket needs to be defined. Like, where is the HERC's role? If our role is to do some weighing in on there, what kind of supports can we get, and how would that decision be made?
Can I just ask we kind of specialize in making decisions in areas where there's very little evidence. It seems like that's basically what we talk about. But especially in the in this group in UEGS, because I think a lot of the more straightforward stuff gets taken care of at UEGS and elsewhere. So how is a cultural consideration different from consideration of values and preferences?
I think what the group was really expressing was that there is evidence here, but the evidence of, so it's not like it's never been studied. This has been studied extensively, and there is evidence, but the evidence is really equivocal that it has any net health benefit. So we have evidence of lack of effect or of no effectiveness, but yet it is a highly preferred procedure by certain families, certain people. There are other similar things. You can think of like ear piercing, perhaps or nose piercing of infant girls in certain populations. There's other things that we also don't pay for, but are very culturally desirable. And so where are the edges of that? Where's the edge of something that doesn't have a medical benefit, but yet might have other benefits to somebody?
And it's a medical procedure, but it's not medically necessary. I mean, we cover our world is more like, is the evidence there? If it's medically necessary, it's a lot easier. Then we have a good decision-making tool, and we use the model for how we rate things. But this is more, it's looking more at determinants of health.
Yeah.
It's gonna affect how someone can pick a wife, or how they're accepted even in their, peer group, in their own cultural families. And so I think my point was, I think that's a policy question. If the OHA's goal is equity, and then there's just such a clear gap between private pay and those in our population that we serve that don't have access. So I thought it was really helpful when you read the statement from the OHA.
Oh, would you like?
Yeah, I think.
Katie, do you have a comment first?
Yeah. I mean, I think, we did have a good discussion about this, and it's kind of hard to recreate the tenor of the entire thing, but I do think that it's not that there isn't medical evidence. This is a procedure that does have complications, and it does seem to be that there is an effective coverage guidance or not as to whether or not the Medicaid population has access to this procedure. So it's complicated. Again, the values and preferences side of things is something that we consider, and then where that how that merges with culture and religious backgrounds and differences, that I'm not clear about. Where does value and preferences merge into culture and religion? And so I think what this is a little bit of an uncomfortable space, because there is some medical evidence that doesn't necessarily support a medical benefit to circumcision. And that seems like a space that we are in. But then it does look like that there are equity ramifications to not covering this, meaning that people who then don't receive access to this treatment is not kind of balanced from a racial standpoint. So those things are all worth discussing, but again, it's not that we are not able to consider values and preferences, and it's not that we didn't consider evidence. It's just that this is a nexus of all sorts of interesting places.
Larry, do you have a comment?
Yeah, I had some thoughts on this. Couple different things. From a cultural standpoint, if this is something that a particular culture feels is important, and if it is not covered, I'm wondering, the question comes up in my mind, are there people in that culture who would not doctors, who would perform this procedure? And if they did, is there a higher risk of complication, which would then require additional medical treatment? So that is, although we're not looking at things from a cultural standpoint, I'm wondering if that could actually create a risk that would require more care. That's one thing. Another is that I looked up the recommendations by the American Academy of Pediatrics and also American Academy of Obstetricians and Gynecologists. And both of those have strong statements supporting neonatal circumcision. I don't know where their research comes from that those statements are based on. I think that would be important to look at. Additionally, I happened to look at a paper that came out of Missouri, written by 3 MDs at a children's hospital there. And they had a very interesting, this was also a paper, I believe it was a meta-analysis, and it was in support of neonatal circumcision. And there were two, I think the paper is important to read, and if staff would analyze it, I think that would be great. There were 2 things that I read in that paper that really struck me. One is that without circumcision, there can be some problems about that show up later that that need to be repaired. This is separate from the circumcision, and it may, I believe, also it may require circumcision. And then when that circumcision is done outside of the neonatal period, there's a much higher rate of complication. So I think that those are important things to look at, and if staff could go back and take a look at those things, I think that would be great.
Thanks.
Yeah, I can read that. So just to ground everybody, OHA has adopted a definition of health equity, and I'll just read that now so we can reflect on that in light of this discussion. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersection among these communities or identities, or other socially determined circumstances. Achieving health equity requires an ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So obviously that's very high level and broad, but you can see some points of intersection, and you can see some points where it might not.
Yeah, it's a challenge because at least to me, it's so broad that you can read a lot of stuff into it. But, yeah, go ahead.
Because I know we haven't had.
Yeah, well.
I think if we view health, so there was health and well-being in that statement there. We have, mind, body, spirit, or any way you want to kind of think of what is health and well-being. And if we think of just medical necessity or the medical literature, it's usually just about the body. So are there consequences to the body with these procedures or risks there? If we bring in social determinants of health, that has consequences that can show up in health later across the lifespan. And that can also, that, if you think of that as health, I think that gets more towards the health and well-being model, and social determinants of health have a bigger influence on the person's health than necessarily medical intervention. And so I kind of think if we're gonna get another center for evidence-based type, if we pull in another evidence review type organization, this might be a really good topic for them to look at, because if we look at like the second order consequences on down the road of individuals who were not circumcised when that was the cultural norm, and then they don't have access to things that they would have had access to, what are then the health outcomes later?
In other words, I mean, those are health outcomes, right?
Yeah.
You can
Health
measure,
outcomes later, yeah.
you can measure distress and psychological
right,
outcomes and
yeah.
all sorts of things, whether or not those things are measured.
Yeah.
But yeah, fair point.
I appreciate the review. I would caution regarding private payers and the analogy. Private insurance covers many things that OHP does not cover. For example, epidural steroid injections or different procedures. So I think private pay uses a different methodology for what they're covering versus what OHP covers. And that would be my caution.
And it was brought up this morning, they have business models and business pressures and
External influences.
Yeah.
Yes.
I guess the challenge there is that HealthShare is a CCO that is covering, so it creates discrepancy in the OHP population, depending on where you live.
Well, I wonder if there's room there to kind of innovate or experiment a little around this issue. I'm not, because I think we've talked about it before, each of the CCOs have these, kind of discretionary funds. And I mean, in this case, the cultural questions to me are a little bit challenging because it's a little different from values and preferences in that the cultural norms are specific to specific groups, and those are going to vary greatly from group to group. If you're talking about a specific population, in this case, the Afghani population, and they're located geographically, and I mean, I don't know how kind of localized they are in Oregon or not, but you can imagine a circumstance in which CCOs that are responsible for caring for a large proportion of that specific population might have in their interest to use their discretionary funds to cover something like this, to support their local community. In other words, is there a way to kind of make this more hyper-local than even like a state level decision?
interestingly, one of the other medical directors, or one of our consultants, used to be the medical director in Louisiana, and he said that's how they solved it. They had a local level, it was discretionary. So the state had a policy not to cover, so it sounds like this is played out in different ways around the states.
Because I think we have to be mindful of, in this body specifically, the precedent aspect, because I'm kind of, the cultural aspect. I mean, we're raising my kids Jewish, my wife's Jewish, and we have a funny story about their own circumcision. My pediatrician in our house supervised my mom, who was a pediatrician, which is a funny story. But anyway, so I mean, I have my own, whatever tendencies to want to do, but because the evidence issues, we have to worry about precedents. And if you say, okay, well, in this case, it is equity in this case, what happens if something else comes up and, it's framed as a cultural issue, there's, no evidence to support it, what do we do in the future? So I think the CCO part, you don't have to worry about that quite as much because you have discretionary funds to work with your community in whatever ways the community, kind of values. I think we're bound a little bit by some other considerations.
One more question. Did it come up regarding the place of the neonatal circumcision, regarding after birth in the hospital versus outpatient in the pediatrician's office?
I don't think there's any data on that. It's really just broken down by neonatal, which is actually not neonatal. It's kind of first couple months versus later.
Okay.
Yeah, but sometimes it's in the hospital, sometimes it's in the office. And in some communities, they'll have Moyle, who is a specially trained person in the Jewish community, will do it.
Okay. And I mention that because folks that do want it pay in the office is substantially less expensive than in the hospital due to the hospital charge.
Right.
In those. Okay.
Yeah. And that,
It's cash pay. It's usually, that was, yeah. How it works now.
You can change by hospital too, because where I was trained, CCO wouldn't pay for it, but the hospital would for training the residents for a while. I don't think they're doing that anymore, so it can vary kind of that way too.
and years ago, before HealthStart started covering it, I know OHSU, if you were cash pay, they would do it in the hospital, and then the clinics had like a set fee that they would charge for it, and it was cash pay.
And that's how it was when I was.
Are you able to hear us online? Okay.
So I think we should get on to the next topic, but I guess you're probably hearing, sounds like similar to what you guys discussed earlier, in general, kind of compassion from this group in terms of the cultural values, but concern about setting precedents given the evidence, and perhaps there's a workaround through local means.
I guess my question at VPBS this morning, they asked if I would consider taking this to OHA leadership to get some guidance. Is that something you would like me to pursue? Or do you just want to leave this at?
Sure, I mean, I think that's fine. I guess we don't want to just kind of keep, like kicking the can down the road
And
kind
you
of thing,
could
but,
decide, we want to affirm our position of non-coverage, full stop, that we're done. That's a decision you guys can make.
yeah, I mean,
Or,
I would love to know more about this like CCO kind of coverage aspect of it, but
so
I don't know if there's anything I know.
HealthShare has expressed that because we asked them, like, are you covering it? They are doing it because of a business model, because of like contracts with providers and providers saying like, we won't contract, like, that kind of level thing.
Gotcha.
And maybe, who knows, advertise, there are many reasons why an entity will choose financially to do something.
Area I do want to, it's certain IDSs within HealthShare.
Oh, I'm sorry, yeah.
Right, not the entire HealthShare, but certain IDSs are covering and certain ones are not.
Yeah. I wonder if there's a way specific, because this was brought up by the Afghani population and they came to the listening session and kind of requested it.
Well, and they, at least the two people who spoke at the listening session live in the Portland area and are probably covered by one of the parts of HealthShare that would cover neonatal. But they were specifically saying, we're getting denied when like our 5 or 6 year old boy needs this.
Yeah.
Because that CCO is saying, no, that's OR, that's,
Right.
20, 30,000. We will not cover that, so. That they expressed support if we wanted to cover neonatal or newborn, but they were specifically saying they were having trouble to access. And even older than 6, like when somebody is a refugee and comes here at 12 and they haven't had access to healthcare in Afghanistan.
We have a comment from Larry. Larry, if you can hear us, go ahead.
Yeah, I'm just wondering, because of the AAP and ACOG recommendations, a couple of questions come up in my mind, and I don't know if there is this, but it would be great if there was some study or analysis regarding the cost of circumcision and the anticipated cost savings of other care due to circumcision. I'm just wondering, and I also just wonder what's the actual cost of neonatal circumcision in the hospital. I remember, I think I performed 1 or 2 neonatal circumcisions as a first-year resident, but I've never done one since, and it's been more than 20 years.
So in your materials, there was the best that I could find on this. There was a study looking at lack of Medicaid coverage and sort of what the downstream costs were. There is an increased cost, not surprisingly, in needing to do circumcision in older boys. So if you don't cover it and you don't have coverage of infant circumcision, there is a higher cost down the line of possibly needing older boys circumcision, but you've also because that population. Yeah, there are some conditions that can be prevented with a circumcision. You're always gonna have some older boys requiring circumcision for medically indicated reasons. You're never gonna get rid of that. Even in some cases, the parent is adamantly opposed to having a circumcision, but it's necessary for the health condition of the child. And then it did reduce the rates of a couple of things like balanitis, but that was a dramatically tiny rate. And the AAP's guidelines are based on mostly on studies done in high prevalence of HIV countries in Africa. And then there's also a reduction in febrile UTIs, but again, that's one of those things where it's incredibly rare and you may get a little bit more rare.
Yeah, the other concern is what I was taught was that circumcision actually helps to prevent HPV transmission it's that with circumcision there is a lower risk of cervical cancer in partners of men who are in women who are partners of men who are circumcised. Now that may I think and cervical cancer is, although we screen for it very well now, and we also do have a vaccine against some varieties of HPV, I think that that is not that's a significant benefit, but does it actually exist? That is another question. And if studies are only coming out of Africa, where the conditions are very different from here, it's very difficult to mix to compare apples to oranges. But that is also if that is in fact the case, it's a significant benefit.
All right, so I guess we're left with Jim. Oh, I'm sorry, Linnea?
Hey there. I was just kind of wandering around in my head a little bit about the psychological kind of implications for some of the older males. It's a little less now, but I think historically you get to gym class, things look different. There can be some psychological issues too, and beyond the cultural issues. So I just wonder if there's literature or a place to do some review there, because I think that may be another area that we're not looking at.
Yeah, and just as sort of along that line, the rate of circumcision in Oregon is definitely the minority of boys. So you're more likely to have uncircumcised kids in your gym class than circumcised.
Maybe, yeah.
Yeah, and it didn't used to be that way. So that I'm just reflecting, like, it's a cultural shift, but I just want to be mindful that that could be a presenting reason, and it would be a case by case basis. But I just think, and it could be done for those reasons. But I still think there's occasionally that shows up.
Yeah, I think it's a fascinating topic. We are we passed my hard deadline already, but.
Let's get OJ.
Yeah, I guess we can get more input.
I will get some feedback for you.
Yeah. I do think it's a fascinating question, especially when you think about equity specific populations and what does it mean in relation to the evidence, and what does it mean for how we wrestle with this? And Liz made a good comment about, not that, I mean, this will blow up our conversation even more, so, but how does this relate to gender affirming care and, you know, the evidence concerns that we just heard, and those are covered by statute, this is not, you know, what does that mean? I don't know, we're not gonna figure it out right now. I don't think.
No.
But
I think that's why we need to ask, because I feel like
Yeah.
it's definitely more of a policy. It
Yeah,
has to start as a policy question.
We will get whatever guidance we can and bring it back to you all. Should we take maybe a 5-minute break and then?
Sure.
The scope statement?
Yeah.
All right, so we will go on mute for 5 minutes, everyone, and be back for the scope statement
All right.
on sleep apnea.
Can I do this?
It's official.
Great.
Are we taking a break?
Yes, we are. 5 minutes.
Oh, okay. All right, thanks. Okay.
let's go ahead and get started again here together.
That's not quite
Yeah.
I think that's what everybody was.
All right. Dash.
Unmute us. Well, now I have it stuck in my head. Ozempic. Oh, wait, we're not on mute anymore. Okay. Advertising works. It does work.
All right, so we are gonna get through the scope statement. So. All right. So this is for the next coverage guidance, surgical treatments of obstructive sleep apnea. So we discussed this draft scoping statement at the last EBGS meeting. So I think our goal today is to kind of discuss this. So obviously this is not, the center hasn't done the review. This is to guide the review that will be done. And I think Marcus, are you gonna walk us through this here?
Yep, I'm happy to. So as Devin mentioned, my name is Marcus Bachhuber, and I'm a clinical epidemiologist with the Center for Evidence-Based Policy. And I was formerly Medicaid medical director for the state of Louisiana. That's who Ariel was referring to earlier. Yeah.
Thank you for
Yeah. So no secret there, no secrets here. So what we'll do first is we'll go over the scope as amended by EBGS, and then at the very end of this document is a change log where we can I can review what changes EBGS made. So the overall topic is surgical treatments for obstructive sleep apnea. And sleep apnea is a disorder when a person frequently stops breathing during sleep. This can result in a low oxygen saturation in the blood and can result in problems such as daytime sleepiness or falling asleep during everyday activities. And it's associated with a wide variety of cardiovascular conditions. So the population reflects that. We're looking for at adults with obstructive sleep apnea. And the reason for that is because children with sleep apnea often have congenital issues or other issues that are distinct from adults. So the interventions that we'll be looking at are surgical airway interventions, including but not limited to those in the upper pharynx. So that's the uvulopalatal pharyngoplasty or UPPP, tonsillectomy and adenoidectomy, as well as those in the lower pharyngeal and laryngeal area. And those are tongue reduction procedures, advancement or stabilization procedures, epiglottis correction procedures. The next category is kind of more global airway conditions or interventions. These are maxillomandibular advancement or expansion surgeries. And then the last category is upper airway nerve stimulators. So these are implants that stimulate upper airway nerves to improve breathing during sleep. So we've excluded the following interventions: nasal procedures, mandibular advancement devices or appliances, non-invasive positive pressure ventilation, for example, BiPAP or CPAP, intensive weight loss interventions, such as bariatric surgery and medications. And that's because we're, again, focusing on surgical interventions for obstructive sleep apnea. For our comparators, we'll look at non-invasive positive pressure ventilation therapy, sham surgery, usual care, pharmacotherapy, mandibular advancement devices. So they're excluded from the intervention, but we'll include them if they're in the comparator groups, and psychosocial therapies. And for our comparators, we're also excluding other surgical airway interventions. So surgeries compared to different surgeries, those are excluded for the main key questions. And that will be, those comparisons will be addressed in the contextual questions, which we'll get to down below. So for our outcomes, the critical outcomes are major adverse cardiovascular events, or MACE, procedure-related serious adverse events. And the important outcomes are clinically meaningful changes in validated daytime sleepiness scales, improvement in disease severity as measured by polysomnography indices, for example, the AHI or the oxygen desaturation index or the lowest oxygen saturation, and validated quality of life scales, both sleep-related and overall. So some outcomes that we considered, that were considered but not selected for the tables were all-cause mortality, change in A1C, remission of hypertension, fatigue-related accidents, and other polysomnography-related outcomes. For our study designs we're looking at, it's for the key question 1, looking at effectiveness of surgeries, we'll consider randomized controlled trials, RCTs of any size, or comparative prospective cohort studies with greater than 100 participants conducted in the United States or in very high human development index nations. And that's kind of our standard geographically where we look for things. For key question 2, for the harms, we'll include RCTs and prospective cohort studies, systematic reviews, as well as systematic reviews, including retrospective cohort studies, case series, and case reports. For exclusions, we'll exclude those RCTs conducted in non-very high HDI countries and individual retrospective cohort studies, case series, or case reports. For follow-up, we will include RCTs if they have a follow-up of 12 weeks or greater. That's total study duration. And then for cohort studies, we will look for 6 months or greater follow-up. And publication will include those published in the year 2000 or after. And for systematic reviews, those published in 2014 or after. So the key questions are, what is the effectiveness of surgical versus non-surgical treatments for obstructive sleep apnea in adults? Number 2 is, what are the harms of surgical treatments for obstructive sleep apnea? Number 3 is, how does the effectiveness and harms of these interventions vary by A, intervention characteristics, or B, patient characteristics, like the ones you see there? For our contextual questions, we have, what is the evidence of effectiveness for surgical interventions for OSA on outcomes? So these are the outcomes that we selected from systematic reviews that include observational and non-randomized studies. And then what is the comparative effectiveness of surgical interventions for OSA from randomized controlled trials? And then what is the cost effectiveness of surgical interventions for OSA? So as far as after our presentation to EBGS, several changes were made that are reflected in this document. So the first is that we removed nasal procedures. So those were previously considered, but they were removed mostly because OSA doesn't originate in the nose or nasal area. We made changes to the comparators. So we removed no treatment as a comparison arm because CPAP really is the standard first-line treatment. We changed the outcomes. So we removed mortality and added procedure-related serious adverse events as a critical outcome, and added clinically meaningful changes and validated daytime sleepiness and removed harms as an important outcome. We also shortened cohort follow-up from 1 year to 6 months and revised contextual question 1, and this was in response to feedback from EBGS. So that is all I have for you. Be happy to take any questions if there's any points of discussion.
Questions or comments?
What was the discussion taken out, all-cause mortality and shortening from year to 6 months?
So, as I recall, the all-cause mortality, so recall that the importance of picking a set of outcomes, whether they be critical or important, is that there's a finite number that can be formally graded by the team, and those end up being kind of the ones that end up being used as the basis for benefit and harm discussions, right? And so you don't necessarily want to, quote, waste an outcome on something that is very unlikely to be available as an outcome.
No, that's right. Yeah, by memory, I thought that was a common one in those studies, but.
All-cause mortality. I mean, and you could correct us, Marcus, but for the population you're talking about, the length of time and size of study you would need to show a difference in all-cause mortality, I think, would be prohibitive.
Okay.
But you'd have to follow people for years and years.
The 1 year to 6 month thing?
1 year to 6 month thing, I don't remember off the top of my head. Do you?
So our experts, or our evidence reviewers did a preliminary sort of look at the world and found some really important studies that had less than 12-month follow-up, and our expert agreed that those were seminal studies.
Practical decision.
raised. Good question. Other questions?
Good, it's clean.
There's no
And we
way it's
would
gonna
like
be
all-cause
this easy.
mortality would be lovely.
Yeah, I know.
But we want,
Maybe I've
right?
just seen a couple, because I remember
I,
that.
I see that someone has a hand raised.
Okay. You've seen that probably for, there was just a big
Oh, so-
meta-analysis on CPAP.
I don't see a hand, so, well, whoever has their hand raised can just speak up.
Oh, Dr. Lamb is here.
Okay.
Let's introduce Dr. Lamb. He is one of our appointed experts for this topic. He is a surgeon who does these procedures. And so let me just read, we have a prepared introduction for him. Dr. Derek Lamb is an associate professor of otolaryngology at OHSU. He is also surgical director of the Dornbecker's Aerodigestive Clinic, where he manages complex aerodigestive disorders in children. Additionally, he's surgical director of the Upper Airway Stimulation Program, focused on nerve stimulation to address adult obstructive sleep apnea. He conducts NHLBI-funded research focused on the diagnosis and surgical management of pediatric obstructive sleep apnea, and has no conflicts of interest that meet our disclosure threshold of $200. I should also say Dr. Louis Libby is going to serve as an expert as well. He is a retired sleep medicine specialist practicing from 1985 to 2021 within the Providence Health System and the Oregon Clinic. During his career, he was board certified in sleep medicine as well as pulmonary and critical care medicine. During his practice, he treated many patients with obstructive sleep apnea and has no conflicts to disclose. He was not able to be here today, but he will be advising.
He's here.
Oh, he is here. Okay,
He is here. It was
wonderful.
Dr. Lamb that was on with us.
Okay, so Dr. Lamb, you had your hand raised. If you want to make some comments, that'd be great.
Yeah, and I'm sorry if you guys can't hear me. I'm currently at O'Hare Airport waiting for a lift. This meeting just happens to be occurring while I'm traveling to a conference. So
We can hear you.
Can you guys hear me at all?
Yes.
Yeah, so I guess I just wanted to dispute the removal of the nasal procedures, because there is a fair body of evidence that the nasal airway does in fact contribute to sleep apnea as well. And you know, I had comments on some of the other stuff, but you guys already sort of went past it, so it's fine. But that one in particular, I'm not sure that I agree with.
Was that, my recollection is that that was excluded for a different reason, is that right?
Well, what he just said was that the nasal airway is not part of sleep apnea, and that is demonstrably not true.
I think what we found was that correct me if I'm wrong, Dr. Bakiru, but the studies conducted that reported sleep apnea as an outcome were not primarily done. The reason for the surgery was something other than sleep apnea, and it was sort of an extra outcome.
And I thought you'd said that we already cover nasal procedures for other indications that overlap, but maybe I'm misremembering.
Partially true. We address nasal procedures. We cover them for things like chronic sinusitis. We don't cover them for like polyps and things, but they're on the prioritized list.
Okay.
So.
Right, so they show up in other areas where they might overlap with OSA, but.
And I believe, what I recall from the evidence sort of pre-survey was that patients who had the nasal surgery and they got the nasal surgery for like chronic sinusitis while they were getting surgery on other things for OSA. So it wasn't, they're not clean.
Sounds like Marcus has something.
I apologize, Marcus, sorry.
No, that's okay. Yeah, that's
Yeah,
correct.
I don't disagree that they're not. I don't disagree that they're not clean and difficult to separate out the indications for, absolutely. But I think in situations where you have someone who has a clear indication for one of those nasal procedures, like say chronic sinusitis, as well as comorbid sleep apnea, like that might still need to be included in the review because it is relevant. There's a growing body of literature that patients who have, chronic nasal obstruction, chronic sinusitis, et cetera, higher rates of sleep apnea, et cetera. So just throwing that out there. And then, in fact, nasal procedures are among the most commonly done procedures specifically for sleep apnea, and with the goal many times of facilitating nasal CPAP. So where you said CPAP was the that is true, and nasal procedures can often help to facilitate that. So.
Okay, great. Thank you. Marcus, were you about to say something else?
No, just to agree with what Jason and Ariel said, that in the evidence mapping that we performed, which is kind of the preliminary look at the evidence to see where things lie, the studies on nasal procedures typically weren't done for OSA. It was done for another reason, and some patients also had OSA. So that was my my miscommunication there. I apologize about that.
Okay. And I think from the practical kind of HERC standpoint, Doctors Lamb and Libby, that these procedures are tied to diagnostic codes. And so if they're covered already for other diagnostic codes that are examined in these studies that are already covered, it kind of becomes a moot point from the HERC standpoint, which I think is part of the rationale. I saw Dr. Libby had you had your hand raised.
Yes, can you hear me? Because I can't seem to get my camera to work, but I think you can hear me.
Yeah, we can hear you.
Great. Well, I would agree with Dr. Lamb that we frequently do nasal surgery to facilitate CPAP treatment, and sometimes in association with other surgeries that are more definitive, the ones that you're talking about, upper pharyngeal, lower pharyngeal, and maxillomandibular advancement. If someone has major nasal obstruction, doing the relatively minor nasal surgery compared to some of those more major surgeries will make those surgeries more effective. But I understand what Marcus Bachhuber is saying in regards to a separate indication for that surgery. You have to have a reason to do it. In and of itself, it's not going to treat significant obstructive sleep apnea.
Thank you. Appreciate that.
Dr. Libby, do you feel, since we have you, do you feel like we would miss? What outcomes do you think would be lost if they were not included, if the nasal procedures were not included?
In terms of the looking at the research database, yes. I don't think you're missing anything by excluding them because as a primary procedure, it is not helpful. Yes, it's helpful so people can tolerate CPAP, but in terms of helpful in terms of treating sleep apnea, obstructive sleep apnea, I do not see a major benefit to primary nasal procedures.
Good discussion. Yeah, go ahead.
I just have one question for both doctors, whoever feels like answering, or maybe you both can. Just in an effort to make sure that the critical and important outcomes that we measure are in alignment with the priorities of patients experiencing sleep apnea. From your experience with patients, do you feel that our critical outcome of major adverse cardiovascular events and important outcomes of clinically meaningful changes in validated daytime sleepiness scales, polysomnography indices, and validated quality of life scales are in alignment with patient preferences of what they think is important outcomes for those surgeries?
I think those are excellent. The important ones are excellent. Major adverse cardiovascular events are great, and procedure-related serious adverse events are very important. I don't think there's a lot of studies that are going to show major adverse cardiovascular events because most of the studies are 6 months, a year, maybe 2 years at most, and it's not enough time for a lot of those events. So comparison between the control groups and the surgically treated groups aren't going to be very different. But the important ones you mentioned here are very important.
I'll just get into that.
Yeah, and I would.
Oh, you're kind of breaking up a little bit.
The other thing that's commonly looked at is control of hypertension. There's some data, and I'm not an expert on the data off the top of my head, but there's some data of improvement both obviously by CPAP and some by surgery also, that there's improvement in hypertension control, whether it's usually fewer medications, maybe not a complete cessation of all medications, but fewer medications to control hypertension. I don't know if you want to include that or not.
Yeah, let's come back to, so we talked a fair bit in the subcommittee about measures like A1C and hypertension. And there's some practical considerations there. Derek, Dr. Lamb, were you trying to say something? You were breaking up. But,
I know, I'm sorry. Can you guys hear me?
Yeah.
I apologize if you could. Yeah, okay. Yeah, I was gonna agree that the rare cardiac cardiovascular, it's probably, there's not gonna be a lot of data on. So I don't know, I mean, you can certainly show that much. Obviously the lion's share is gonna be just based on your, apnea-hypopnea index, but I do, and the quality of life indexes, quality of life measures, I think is a really key one, because there's a number of fairly standard quality of life questionnaires that I think captures a lot more of the patient experience than just the apnea-hypopnea index does, which, everybody acknowledges is an incomplete, and far from perfect outcome measure, basically.
Yeah,
but
thanks.
it's likely to be, yeah, sure.
I actually had and I want to come back to this, but since you're mentioning the polysomnography indices, maybe we can ask about that, and we'll still come back to hypertension. So, one challenge with these intermediate metrics like polysomnography indices is determining which of these is particularly important or which have been linked to real clinical outcomes. Because obviously what we're most interested in is clinical outcomes, and we acknowledge that, the literature is not going to give us a lot of that. But like looking at the IE list here, for instance, lowest oxygen saturation, is that a meaningful index on its own? Or are there certain polysomnography indices that are more important than others? And if so, which of those metrics is particularly, important to key in on?
Well, I'm glad to talk to that. I would think that the apnea-hypopnea index and similar index, sometimes called the respiratory disturbance index, that is a little more liberal in a definition of an event. Both of those talk to the number of events per hour. And there's pretty close correlation between those and severity of obstructive sleep apnea. The oxygen desaturation index is the number of times an event leads to a low oxygen level. So it's pretty closely related to the apnea-hypopnea index, but it includes the oxygen drop. And sometimes that has more to do with the size of the person. Really big people, they might drop their oxygen level a lot quicker than thin folks. And so it has some complexity to it. And a single lowest oxygen saturation, I think, is the least important of all of them. That's one event per night, and it may be out of the norm for that person. So I would think that's least important of those. So apnea-hypopnea index and its related index of respiratory disturbance index would be the most important, and oxygen desaturation index the second most. But I do think the quality of life scales are really important, both sleep and non-sleep related.
Great, thank you.
And if I could just add to that a little bit, I mean, I agree with those primary sleep study measures as well. I think you may also find the respiratory event index is sometimes quoted from home tests, because they can't always distinguish the type of event with some of the home tests, and so you'll see it's slightly different. That's perhaps even a more liberal definition than the RDI, but that's one that should probably be counted as well. Oftentimes, and they're highly correlated typically with the AHI as well. And some other challenges that you may run into in terms of interpreting the results is that the definitions for hypopneas in particular has changed over time. And so some of the older studies, you may not be directly comparable to more recent ones. I think you had said that the time frame for review was limited to 2000, but the change in definition happens since then. So I don't remember exactly when, but sometime in the 2000s, I believe there was a change in the definition for hypopnea. So you may run into issues there. And the same actually with the oxygen desaturation index. They changed from like 3% to 4% sometime, I don't know, in the last 10 years or 15 years, something like that. So there's going to be some challenges there in terms of interpreting the numbers over time.
Thank you.
Totally. Yep.
Thanks. So, I wonder, Marcus, and for the center, if for this polysomnography indices, if it's worth tightening that list up a little bit. So, because otherwise I worry that it's going to be hard to summarize something like maybe prioritizing the AHI and those related indices that both the experts mentioned. I also wonder, based on what we're discussing now and Lisa's questions about what's important to patients and our experts' comments about the importance of quality of life, if that should be promoted to a critical outcome and if the MACE should be changed to an important one.
What would the difference look like?
I mean, I don't.
Yeah, so Marcus, how would that change much more?
I think, and Shawna, correct me if I'm wrong about also, I think it would just change how we label them, what we classify as a critical or an important outcome. I don't think that the result, and it would change the order that the results are presented, and I don't know that it would change anything about our research process.
Because I think it categorizes the patient centered.
You'll just say it sooner in the grade table.
Yeah. So I mean, it's just like the patient, like you're saying, patient-centeredness aspect of it. Okay, so we were going to come back to these intermediate metrics like hypertension and sugar control. So as I recall, one of the challenges with a continuous outcome metric like blood pressure is it's hard to summarize that and to know what to do with it as a outcome metric. Number of medications used is easier, right? Because you can, that's more firm. But average blood pressure over what period of time, when you check the blood pressure, are you just checking this one measure at the end of the study? And what does that mean? I think we as a group felt like that got really messy and would be hard to interpret.
There's a lot of medical conditions that can be improved when sleep apnea is resolved, so maybe that's too heterogeneous.
Yeah, and I think by the same token, the diabetes control, the same rationale. So anyways, I just wanted, that's kind of what we were thinking. Whether or not the group agrees is a different question, but that's why those are not on the list now. Larry?
Yeah, I like what you're saying about, I think bringing up blood pressure is very important. It is, I'm recalling a patient who had high blood pressure that was very difficult to control until we figured out, that he has sleep apnea. So if the studies looked at are limited to major cardiovascular events, I think that misses or potentially misses something that could be very important. So as a family doctor, my perspective is it's better to prevent something than to have to cure it or fix it after the fact. So if there were any studies that looked at lowering of blood pressure, and if that could be related to, if we lower the blood pressure below a certain amount by using some form of intervention, whether it's CPAP or some other intervention, what it does from a statistical point of view, does that reduce the risk of end organ damage, not just major cardiovascular events, but for instance, damage to kidneys, things like that. if those could be, because I think looking at what a treatment could for one condition could help prevent in another condition, I think that if we could look at that, I think that might be useful. Does that make sense?
Yeah, I mean, I think we were all in agreement that hypertension control is important, and it's good to think about the preventive potential of these procedures. I think in a practical respect, using blood pressure as an outcome on its own is a challenge. And I know myself, just from looking at studies of intermediate outcome metrics, you can manipulate those outcomes much more easily than other outcomes in certain ways based on how you measure them and whether or not it's clinically meaningful that the blood pressure at the end of the study was this versus that is a hard thing, I think, to interpret. I think if we had an outcome metric that was number of medications used to control blood pressure or something, that might be a different story.
But if the studies are only 6 months to a year, are you really gonna see a change that early?
You could see in the number of medications. I mean, that's just it's another way of looking at hypertension control, but with a
that's very specific
more
chemical.
firm kind of metric. I mean, we
actually
have
is
to report on blood pressure as quality metrics in our system, like a lot of systems do, and it's horrible to do because you can't even decide which blood pressure you're supposed to use to report and over what time period and all of that.
I think that using the number of medications and if there is a decrease as a surrogate, that actually may be a very reasonable thing.
If I could offer my thought on that. Sorry, this is Dr. Lamb.
Yeah, go ahead.
I'm guessing, I could be wrong, but I'm guessing you're not going to have a whole lot of studies that specifically look. Obviously, if there are any, that's worth reviewing, but I'm not sure you're going to find a lot. But this discussion reminded me, though, that of something we talked about initially in the intro to this, which was that the all-cause mortality was excluded as an outcome, and I think I would disagree with that too, because there are studies looking at mortality, particularly one in particular that I can think of that was using VA data. It's an older study, but it is relevant to this, very relevant to this discussion, because using VA data, they were able to show a significant benefit of the UPPP over CPAP, from all-cause mortality in the VA. And that is it was a retrospective cohort study, but it was with huge numbers using the whole VA database and over a long period of time. And they showed that patients that were treated, when they directly compared patients who were prescribed CPAP and those who underwent a UPPP for sleep apnea, showed significant benefit in favor of the UPPP. I can send you the reference, but there are studies, so that's just one I can think of, but there may be others as well that do look at all-cause mortality.
Yeah, we appreciate that, Dr. Lamb. I think that that kind of study would be excluded from this. And the challenge with that design, and we can take a look at it, but the confounding by indication issues are significant, right? So people that are felt to be candidates for UPPP surgery are going to be dramatically different than those that are left with CPAP as an option. And even after controlling for measured confounders, the unmeasured confounders are going to be challenging. But
I think that there is room for dispute on that, and you could look at how they did their best to try and adjust for confounders, but the other thing is that most people who undergo is that they have all tried and failed CPAP, and so so there may be some confounding by indication that in that study where you have people that are able to tolerate it, whatever. But the point is that I think mortality should still be considered as an outcome because maybe they're missing, even if it's not directly being compared.
Yeah, fair enough. But still, the type of study you're describing, I don't think would be included in these study designs. Val, you were gonna say something earlier?
I was going to ask Shauna and Marcus to talk about two things. They did a really extensive evidence map that EBGS used to look at outcomes and to select the 5 that were the most important and reported. And I think they have a question about the polysomnography indices and just confirming which of those are. Let's come back to
We
that.
have to have some firm decisions on the polysomnography indices, so I think.
But with regard to mortality and blood pressure as outcomes, the EBGS made some judicious decisions about those based on the evidence map.
You know, there's
Sorry, Larry, can we just hang on backburn for 1 second?
Sure.
Let's just nail down the polysomnography index metrics, so we get pretty specific with those, and then we can move on. Is that okay?
I just had a comment about the types of about another outcome that I don't see, but yeah, I'll hang on, no problem.
Okay, we'll come back to it in just a second. So in terms of polysomnography indices, what I was hearing from Drs. Lamb and Libby is that AHI would be the most important, and then there's a couple of related metrics. RDI, and then the home testing one. So the home testing one, that's a whole other question.
That's RDI.
REI.
REI, and there's RDI. But so we're including home testing outcomes in this as well. So I guess those 3 would be the main polysomnography indices.
There was also ODI, the oxygen desaturation.
As a tier below that.
And Marcus, Shauna, though, is it gonna be problematic to do all those? Is that what you're?
No, this is Shauna.
Oh, go ahead, Shauna.
Sorry, Marcus. No, we did identify RDI and REI in some of the scope eligible studies that we're aware of, and it's not going to be a problem to incorporate them. We'll work in the grade.
I think one other little wrinkle with that too is that you may have some studies that specify the obstructive apnea-hypopnea index as opposed to, the total apnea-hypopnea index, which includes central apneic events. And that should be considered as well, because it's arguably the more relevant metric when it comes to outcomes of sleep surgery. But many of the older studies and even some of the newer ones probably maybe don't differentiate total and the obstructive apnea-hypopnea index. Those probably do need to be considered separately because they are not the same thing. But certainly there are going to be many studies that only report the obstructive apnea-hypopnea index as their primary outcome.
So just to put a fine point on that, I just want to make sure that the list of indices in the scope exactly aligns with what we are doing and what the will of the committee is. So what indices should go in this in the parenthetical here? So we have apnea-hypopnea index, respiratory disturbance index, respiratory event index, and oxygen desaturation index, and we're removing lowest oxygen saturation.
And
based
so
on what I heard.
Yes.
Yeah, you can have 2 apnea-hypopnea indexes.
We'll take either one.
So you take either one.
But separate. Yeah.
And then was there any, does it seem like the MACE versus, because I don't see the quality of life in there either, but we talked about that as.
So it's there,
It is?
it's at the end of the list.
Yeah, validated quality of life scales.
Oh, okay.
Yeah, we were
That'll
just
be
talking
moved to
about
critical.
moving it up to critical. I mean, that's just a labeling issue, but it just helps.
But then that makes it 6, not 5.
No, just swapping it out for MACE.
Okay.
Yeah. Sure, unless anybody disagrees.
So elevate quality of life and demote MACE.
And just to be clear, we're demoting it because it's not to be found, not that it's not a significant event.
I mean, yeah.
So that's why I want to be,
right, I mean, right, so mortality, I think everybody agrees mortality is an important event.
We care about
Yeah,
mortality,
yeah,
that we
yeah,
can't track.
And we care about MACE.
yeah, we care about MACE, we
care
care
about
about
MACE.
everything.
But the patient might be more immediately motivated by the quality of life.
Yeah, if we have time later, I can tell a story about the COPD guideline we did where it became relevant, where if you ask patients what they meant, all the doctors rated mortality as highest, all the patients rated it lowest. And it was more adverse events and quality of life that emerged at the top, but
So you're
anyways.
keeping the procedure-related adverse events.
Yeah,
And quality of life for those two critical?
I think so, just to communicate the patient-centered aspect of it. Larry, and
Yeah.
we're gonna wrap all of this up in 10 minutes, so.
I just had one other thing to just bring up, and that is, sleep has been shown to be good restful sleep, appropriate amount of sleep, has been shown to be related to appetite and improvement actually in diabetes. So I'm wondering if that an improvement in fitness because of changes in appetite with better sleep. I'm wondering if that is something that might fit in here.
I can comment. I could comment on that too.
Yeah.
And to Val's point, and Shauna, you're gonna have to jump in and help me. But in the evidence mapping for the studies, we found really limited information on blood pressure and diabetes. Shauna, I don't know if you have any more details there.
Just that it is really sparse across studies. It's present, unlike all-cause mortality, which we did not find in any of the prospective studies that we looked at, but it's barely there.
Dr. Lamb, do you have any information about that?
Yeah, I would guess that I would agree with what the evidence map found. I'm guessing there's very little, probably no data in that regard.
That's too bad.
Lisa, do you have a comment?
If you can suggest that to the NHLBI as a long-term prospective study to fund.
All right, I gotta keep us moving here. Lisa?
Nope, thank you.
Possible solution, if it's appropriate as a contextual question, could we just ask, just from the studies that are found and reviewed, is there any information that we could glean on the impact of other health conditions? You know, like positive, neutral, just whatever else is found. Is that an appropriate contextual question?
I like that idea.
Just FYI, I think Channel Val, I think the center would like you to select what you need to make a coverage decision on this topic.
Yeah, we're not gonna get all the benefits. We need enough to make a good decision.
On this topic.
Because this is gonna be a very long report as it is.
Yes.
We need to talk about that as well. Ariel, she has a few slides.
Okay, yeah, so again, the scoping is important because this is months from now, you're gonna be sitting here,
That's right.
you know, with an amazing report, and it's gonna be a lot of information, and it's gonna be hard to know even what to do with the information that you have. So we have to be judicious on the outcomes that are presented. So with the list we have here, are there any any disagreements with the outcomes that are here? If you propose a new outcome, you have to choose an outcome to eliminate from the list.
That's right.
Can I just ask one simple question? What I heard was the events per hour can be an indication of how severe it is. Is there any benefit in stratifying by severity, what the outcomes would be?
Something we're gonna talk about.
So-
We're gonna
Yeah.
slides it.
Oh, thank you for that.
Yeah, good question. Yeah.
But so then do we need to keep it
Yeah,
or
patient
not?
characteristics.
We'll address it right.
Okay, cool.
All right, go ahead.
Oh, there it is. I see it.
Either Ariel or
Marcus,
Marcus.
do you
It was
want,
a- it was
I'm
a
happy to
plan.
take these, or you can take these.
I'm happy to walk through them, Ariel, if
Okay,
that's
go ahead.
yeah. So There's a couple of kind of bigger issues we wanted to raise to y'all's attention. The first is that there's a large number of interventions being studied. So combining the upper pharyngeal, lower pharyngeal, and laryngeal, as well as the global airway procedures and nerve stimulators into one report may result in a report that's too complex and large and difficult to digest. I think we can all see that kind of looking at the scope. So there's a couple of options here. One is to leave all interventions together in one report. So that's do nothing. And option 2 is to divide the scope across 2 reports. The first one is the surgeries and the second one is the nerve stimulators. And we propose this because the surgeries can run together, so people can get multiple different types of surgery at the same time. And the nerve stimulators are typically studied in a different manner. So
there are also in many circumstances, 2 different populations. At least on the evidence mapping that was presented, the reconstructive surgeries tend to be people with more severe sleep apnea, whereas the nerve stimulators are studied in people with mild, moderate, and severe. So you'll see that come up again.
Okay, so
Seems more
this
same for
really
you all.
this really has to do with how we'd be presented and kind of digest this, but the option 2, we'll still eventually get to all of them. It's just how to batch it. Is that right?
And with the next issue, you'll see it's more important.
Yeah. So for issue 1, is anybody opposed to option 2? That sounds totally reasonable to me.
Option 2,
Okay.
option 2.
All right, so let's move on to the next one.
Which one do you want first?
Do you have a preference?
The more expensive one, the surgeries.
Well, the nerve stimulators are more commonly.
Yeah, let's do nerve
Yeah, stimulator seems
I think
like
that's
where the
clearer, more
kind of
basic
coverage
one.
issue is
Okay.
most pressing.
Okay.
Okay, so severity.
So the second issue is that the treatments may work differently for individuals with different levels of OSA severity and defined as mild, moderate, and severe. However, there's some kind of practical implications here. So patients in 6 of the 7 scope eligible RCTs that we found and all the observational studies had moderate or severe OSA at baseline based on what we can tell from their baseline demographics and baseline OSA data as indicated by the mean AHI scores. And there's very limited OSA severity subgroup data, meaning reporting of outcomes based on OSA severity subgroup. So you can go to the next slide. So those practical implications really limit what we can do with OSA severity. And so here there are three options. The first is do not stratify results by OSA severity. So that's do nothing. Option 2 is stratify results by mild versus moderate or severe OSA. And option 3 is limit the scope to moderate or severe OSA. And option 3, we think is an appealing option because surgery itself is a second-line intervention, and the fact that there's 6 of 7 scope-eligible RCTs only include moderate or severe OSA, and there's also very limited reporting of outcomes by subgroup. So that's going to be the more relevant scope for this intervention, potentially.
And one additional, just super complicated, is that this is really for the reconstructive surgeries.
Yeah.
We could still stratify, probably not much, but we could try with the nerve stimulator, I believe. Is that, am I speaking a true statement, Marcus?
Shauna, can you let me know what you found for the nerve stimulators?
I believe all the nerve stimulator studies were actually, when you looked at baseline AHI, were done in populations with severe OSA in the end, although I think they all enrolled participants with moderate to severe, or at least they said they did.
Yeah.
We could
Can
just
I-
limit to moderate to
can
severe,
I-
not
Yeah, go ahead, Dr. Lamb. Go ahead.
I was gonna say I think pretty much all the data that's out there about the nerve stimulator is gonna be limited to moderate to severe because that was the population, that was the inclusion criteria for the initial STAR trial. That was what led to the FDA guidelines for that device. So pretty much everybody in the studies that I have seen, at least in this country, are going to be moderate to severe for the nerve stimulator. I doubt you'll see anything that's less than that.
And this piece of data won't be missing from the report. It would just be more summarized in the text as we looked.
Right.
For
Yes, okay.
a while, didn't find it. There's no data, so that
Yeah.
kind of
option
And,
two
and
for
this
most
is
of them.
helpful because when we write the statement, we're gonna wanna say who it applies
Right,
to,
right.
right? And so if we can say it applies to moderate or severe OSA and have some information there, that's gonna be really helpful. So I think this is fairly non-controversial, right? That it's gonna be, I mean, whether it's option 2 or 3 seems like a little bit of a moot point, because if you
Option
just.
3 will make much simpler
Yeah.
outcomes.
That's fine, so option
I don't
3,
think
and then if you find anything in mild, you'll just
Right.
tell us about it.
Right.
All right, is there another issue? Okay,
I
so
have,
Larry, go ahead.
I have a I don't mean to throw a monkey wrench into anything. I'm
Okay, but we're
thinking
gonna
of-
end the meeting in 4 minutes, so we gotta.
I'm just thinking about outcomes, and in terms of sleep apnea, I think one of the biggest risks is car accidents. And if staff could look at, moderate to sleep apnea with respect to these different interventions and use car accidents as one of the outcomes, I think that would really be some real concrete evidence.
Yeah, there's a contextual question.
Yeah.
What's that?
Oh, okay, sorry. All right, sorry.
Okay, so, we have to vote on this, right?
Is there a third slide?
Oh, is there no?
No,
Okay.
Okay,
Okay.
okay, so we're gonna vote here in a minute. Does anybody have any last minute comments or questions?
One clarification,
Yeah.
the definition of obstructive and severe sleep apnea.
Moderate, severe, is based
Yeah,
on the
moderate.
AHI.
Okay, that's what I just want to be clear, that it's a standardized AHI definition.
Is it too complex to add the contextual question of, is there impact on other health conditions?
I think that's
What I would
too-
say is hold that question, and when you get the report, it may actually inform where you go with it.
I worry that it's too vague and broad
Okay,
to ask the center
fair
to do that.
I don't think
Because
it will
if
change
we
your
cover
decision
it,
making.
then it's gonna help all of those
It will,
conditions
yeah.
regardless.
Yeah,
If we
It's not
don't,
like
then
it's
it's fine
not
line.
worse.
yeah.
So-
I mean, part of this, you don't wanna retroactively decide, oh, we found this thing, and it looks
Yeah.
great for this, and,
Okay.
you know.
So just, I just want to point everyone's attention to the screen. We're limiting things to adults with moderate to severe sleep apnea, and in the report, there will be a definition. There's a standard definition for what qualifies as moderate or severe. We are looking at upper pharyngeal, at lower pharyngeal, and maxillary advancement. I'm sorry, the first 3 dots will be one report. The last dot, the upper
Yes.
airway nerve stimulation, will be a second report that will prioritize first in
Can
time.
I just say though, for population description, why say moderate to severe there? I mean, we know that that's what it's gonna apply to, but it doesn't make a difference, but I think in communicating to the public, there's no reason to suggest that the report is more limited than it's going to be. You search, you already.
Yeah,
searched.
so there is one study that included those with mild sleep apnea. It was quite different than the other studies and used a different intervention. I don't know if you're interested, we can tell you more about that, but that would be the rationale to limit the scope to moderate or severe, in that it narrows the reported RCTs and studies to the population of interest.
Right, I guess what I'm just saying.
Intervention is also surgical, so that's never gonna be first line either, right?
Yeah, it's not, I mean, it's
Right.
never gonna be, but I guess I'm just saying that you already looked for it and searched for it and found it. And it kind of unnecessarily conveys a restriction to the report that doesn't actually exist. When we make our recommendations, they'll be applicable to moderate to severe sleep apnea. But, I mean, I'm just thinking about public comment and
Yeah.
stuff. There's no reason to limit it up front.
Well,
You know,
except for, well, how will that affect, just Marcus and center folks, will that affect the search and how much search resources you need if we don't limit it?
oh, I see.
Yeah, so, and it also affects how we present the results. And Shauna, can you tell a very brief summary of that study, that one study that included mild folks? I remember it was going to be a very
Sure.
limited interest to the group. Yeah.
Yes, so this was a trial of 32 people that was conducted in 2009. It was of radiofrequency surgery of the soft palate compared with sham surgery. This was the one that was limited to individuals with mild OSA. It's the only study we have of this procedure, at least that we know of in my evidence mapping. We have not yet conducted all of the database searches. But this is really somewhat different. It's an office procedure. It's done in about 10 minutes. It's like an ablation that's done with local anesthesia. And I want to note that this type of procedure is actually considered to be investigational by Medicare, Aetna, Cigna, MODA, Regents when we looked. So we're not really sure this would qualify anyway.
Yeah, so the evidence mapping is a preliminary, as you know, and the limiting the scope would streamline our ability to do the search and compile the report. As folks mentioned, it's already quite an extensive report.
Okay, fair enough. So I think we can keep it as moderate to severe then. I'm just trying to avoid, comments later down the line that are unnecessary, but okay. And now we got to vote before it gets too late. Larry, do you have another comment?
Oh, no, I'm sorry.
Okay.
Sorry, I found that.
Okay.
Thanks.
All right, so I think we're ready to vote then. Does anybody want to vote to approve the scope statement as it appears on the screen?
I should do it. I move to adopt
The modified scope.
the modified scope statement.
Or since you
I'll
got
second.
it, you
I'll
got
second.
seconded, okay.
I succumb to
So,
peer pressure.
Then we'll do a verbal vote in the room, just go around, you already.
Aye.
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 And then everybody online, heard Larry.
Put in the chat.
Aye.
Okay, great. All right. As the results trickle in, I think we approved it.
I'm not getting a whole lot of votes in the chat.
Oh, I think everybody said yes.
Yeah.
Everybody said yes. Okay, verbally. Never mind. Then that's
Yeah,
unanimous.
okay.
All right. Great. I think that's it.
Okay, so, all right, next meeting is August 8th, although
Does anyone know if they have conflict with August 8th?
Yeah, I'm gonna be gone.
You're gonna be gone. We've heard of a couple other, Holly Joe's gonna be gone, so we're gonna look at other options, so watch for emails, and
Prime vacation month.
prime your vacation plans, yeah.
Nobody can have vacation or August.
That's gonna happen.
Summer Excel spreadsheet.
Intentionally went this week,
Okay.
that week, to avoid the herd meetings.
Well, thank you all for the great discussion. Very good.
There we go, theater over.
Okay. Thank you. Bye-bye.
Everyone.
Thank you.
Thank
Bye,
you.
good night, bye.
Thank you, everyone.
Thank you. Oh, no. I worked.